देखिए इसको फ़ोन करो जल्दी लेके आए, हम बताओ बच्चों को छोड़ के कैसे आए।
आईटी का हेड ये है। कुछ एडिशन नहीं करना हो तो बिल्कुल मना करो।
or darker if a person is microscopic or a person is tubular, so then it is easier for a tubular surgeon to transition to endoscopic spine surgeon. The goal, as we all know, is to get the surgery done, to be proficient while doing surgery, to be fast, and we shouldn't be getting intimidated by the name of endoscopy. The challenge initially is longer initial OD times. Bleeding control fear is one of the biggest fear where the new surgeons see red screen and they don't know. Now they are not able to see anything on the screen and what to do now. So that is one of the biggest challenge and that is one of the biggest fears initially when we start our UBE journey, and everybody has it. Loss of orientation is another thing because you are seeing in 2D the anatomy which is in 3D. In microscope, we know that everything which we are seeing is just in front of our eyes. We have depth perception, we have left to right perception. But in endoscopy, the perception is divided between what you are working on is different and what you are seeing is on a screen. So it is dissociation. So the mind need to be equipped with that dissociation. Two-hand coordination issue. When we are working under microscope or tubular surgery, both the hands are working in synchrony. Here, both the hands are working through different ports. So, and our eyes are seeing it on the screen. So, when we are doing this, it takes a bit of time for us to get acquainted to this kind of pattern where the hands are working independently, both of them they are working independently, and our eyes are independent, seeing it in a different way, and then our brain has to actually interpret all these feedbacks in a coordinated way. But the key question and my topic of lecture here is, can we shorten this curve intentionally? As I've already said, anything which can be having a algorithm can be engineered, and anything which can be engineered can be mastered. Defining the learning curve. Learning curve in UBE includes, first of all, endoscopic orientation. Somebody who has done work with earlier kind of endoscopes or even tubular work like Descendo or EasyGo systems. So it is easier for them to transition to UBE because they are already doing half of the work and their mind is already having that kind of orientation. Portal triangulation is one of the other fears where if a person is not conversant with how to place the ports in a better way so that the ports are not too close or they are not too wide, then the person or the surgeon would be lost during surgery and he won't be able to complete the surgery in that setting. Instrument and water coordination. This is a fluid-based medium study surgery. So this is a big transition and this is a big fear for every one of us because we as neurosurgeons are always have been trained on the air kind of medium, and this wet medium or the saline medium is new for us, and we have reservations, we have doubts regarding how we would be able to manage with the surgery under constant saline irrigation and constant, I would say, mess. Hemostasis under saline. It is totally different how you do hemostasis while the air is the medium or in the open or microscopic surgeries where you can directly go and cauterize it with bipolar and the hemostasis is done. In under saline, it is a bit different. We use different tools and there are different techniques to get hemostasis done. And the other thing is even a small bleeder looks real bad. The whole skin gets red and we are lost. So hemostasis under saline is very important to begin with when we are starting with our UV journey. Bone and drilling confidence. When initially we start drilling it under the water, there are a lot of factors, the tactile feel, how the high-speed drill would behave under the water, and how it would be able to do the surgery using a high-speed drill. So that is one of the other factors which prohibits or which prolongs the learning curve. And efficient decompression workflow, that is what I was talking about. If we create a workflow or if we set a pattern, then the things become easier and the learning curve becomes shorter. The data on learning curve, it suggests that the sweet spot is at around 20 to 30 cases. A lot of data has been generated, and this has revealed that when a person starts doing UBE, in initial 1 to 10 cases, you work like just a resident because it's a learning curve. So in initial 10 cases, you would be like, yeah, I'm lost, I won't be able to carry it further, or I need to convert. So initially, you don't have to be disheartened, you need to continue with those cases because it happens to everyone, even the master started like this. So in first 10 cases, you would be lost, you would be disheartened, but do not stop the practice or do not stop doing UBE. But next 10, from 11 to 25 cases, this is the phase where everybody starts gaining some momentum, some confidence, and the surgeon starts to he starts learning the techniques to make it faster and make himself more efficient during the UBE surgery. In phase 3, I would say, in my own experience as well, once you cross the threshold of 25-30 cases, then you start seeing the things differently, and you start loving this technique. Earlier, once you haven't completed 20-25 cases, it feels like a burden, and you feel like, why I'm doing this? I can complete a microsectomy in 40-45 minutes, and there is no need for me. I'm an accomplished surgeon. Why I need to do all this hassle? Even OT staff is doing, डॉक्टर साहब क्या कर रहे हैं पता नहीं, पानी पानी कूड़े में कर दिया है. So this is something everybody has that kind of resistance. Anesthetist is not happy, OT staff is not happy, you are not happy. So it gets into your mind, why we are doing this? But this is for initial 15-20 cases minded. Once you have crossed that threshold, then you won't look back because you would start loving it. And even if somebody asks you that there's a simple list, what you would like to do, you would always say that I would like to do an UBE surgery for this patient because that is where your heart will belong. There are 4 phases of UBE learning. Phase 1 is disorientation. Mainly disorientation comes from water turbulence, how to handle the water pressure, what are the factors when we are doing surgery underwater. Bleeding anxiety, as already talked about, and loss of anatomy. Again, once you are seeing the thing differently in 2D, so the feeling of the anatomical orientation becomes different because there's a limited scope view which you can see in while performing UBE, and the whole anatomy is not in front of you, and you need to guess. I won't say guess. You need to interpret the anatomy which is visible on the screen, and you need to be having a mind map about the adjacent anatomy, where to go and where not to go. Second phase is control, where you start making identifying marks in a faster way, you talk in a better way, and you start having a better bleeding control. Third is efficiency, where you know which instrument you need to use and where, what is the importance of drill here, what is where you would be using kerosene forces, kerosene upcuts, and how to use the drilling, and up to what extent, which burr, whether you need to use a diamond burr or a cutting burr, so that would, or a hooded one or a without hood burr. So that then you would start seeing the difference between the instruments, so that you would be able to use those instruments in the most proficient way. And phase 4 is the flow. The flow is The best way is once you get to this point, then you are already proficient and you are going with the flow, and you are this becomes your muscle memory, and you don't have to think about what to do next. You already know that I've done this step, and next step is this, and this is a mechanical flow, and you will go with the flow. So technical hurdle number one is triangulation, as we have all heard about the triangulation. So what is triangulation? Triangulation is basically when this is a two portal, we create two ports, right? They are usually 3.5 centimeters apart, and the aim is that both the ports should, the tips of the instruments should just see each other. They shouldn't be crossing each other. If the ports are too close, that would be like a chopsticks fighting with each other. Or if the ports are far away, then you won't be seeing the instruments with the camera. So the aim is to have that sweet spot where you would be having the ports marked in a standard way, and you would be having a good triangulation. The fix is standardized portal placement based on the set rules. So as we are having live surgeries also today, so you would be seeing how to mark those the entry points. In fusion cases it is different, and simple microscopic endoscopic discectomies, the port markings are different. So as you can see here, the ports are around 1 inches to 3 centimeters apart, and this is the perfect kind of triangulation which you can achieve. And the second thing is regarding the left and right orientation. As we have always been trained on microscopic surgeries. So the operating surgeon always by dictum, we have already always seen the anatomy standing on the left side of the patient with the head up. So the mental map we are having about the anatomy is always we have seen it from the left side. So when we are using this endoscopy, then we are in initial few cases I would say that we need to go in from the left side, so that the anatomy which you are conversant with, you should be able to see it in the way your mind sees it. Because when you enter from the right side, the whole anatomy becomes reversed, and you are not used to it because you have never seen it that way, that the lamina or the interlaminar window head. So that is how it looks from the right side. So that is totally reversed. The point is here is the working hand. If we are working on the left side of the patient, then the working hand has to be the caudal hand, because that is the right hand. For a right-handed surgeon, the working hand has to be the right hand. So nothing to remember here. The only thing is the right hand is always working, left hand is always holding the port for the camera. So when you are working on the going from the left side of the patient, so the right hand will be the caudal hand, and when you are working on the right side of the patient, the right hand would be the cranial hand. Technical hurdle number 2, bleeding and visualization. As we have already talked, this is the kind of screen which we get if there is even a minor bleeding. Many surgeons get intimidated with this screen, what to do next, and whatever they do, they are not able to get off from this point further, and they abandon it, and they convert it. There is no shame in converting in initial few cases, because that is how the learning curve goes. So once you see the screen, you need to actually learn how to manage. Strategies to accelerate. When you see this kind of screen, the good point is the saline we are working with. In normal patients, we are keeping, I'm not using any RF pump for the saline. I'm just keeping the saline bottle at my shoulder height. So that gives me enough pressure so that I'm able to complete my surgery without any, as Dr. Osha was saying, that there can be chances where we can introduce fluid into the neural tube, or it can be pushed up. But if that is usually when you're using a water pump, but if you're using the gravity based saline, then it is hardly the issue. So I in my OT, I'm keeping the saline at around the surgeon's height, and we are keeping it like that. Then the optimum pressure is there. But if this blood or the red screen comes up, then I keep the DURP pump. So one or two puffs of air we inject into the saline bottle. It increases the pressure momentarily, and once the pressure increases, the bleeding 90% of time the ooze stops, and you get a clearer view. RF ablation. RF is another thing which is exclusively we are using in UBE, and it is a real good tool. You need to know how to use it. There are multiple type of the tips. One is the most commonly used is 90-degree. The other are end on the pointed one, the hooks. But they are all real good, and they most of the times they come to your rescue when you are dealing with a bleeding or a red screen. The third and most important point is keep dissection on the bone. The bone is our friend. When you are stripping off the muscles blindly, you are going into the territories which you should not. Then the bleeding comes up, and those bleeding can make your life harder. Keep yourself on the bone. Dissection of the muscles should be off the bone. It should be clean. It should not be messy. You should not be attempting multiple punctures for dilation. It has to be in one go so that you are not creating multiple tunnels in there. And once those tunnels get made, then the chances of bleeding are more. So keep your dissection on the bone. Controlling bleeding is a major fear. Bleeding slows beginners. Protocol is maintain saline pressure, increase line pressure, use RF early, drill bone, and stay on bone, stay oriented. This is just a small video. I would just show it to you that you are not able to see anything here. And there's an epidural vessel which is getting, which is bleeding here. And this is an anon tip probe which we are using. And you would just see in a moment how it makes a lot of difference. And once we cauterize it here, the vision becomes so clear that in just a few seconds, you need to just know how to use these instruments, and your life can become easier. Biggest mistakes growing the curve are starting with complex cases, migrated disc, revision surgeries, bilateral disc decompression. Do not have to attempt bilateral decompressions, and no prior hands-on training is a big no factor. You should have prior hands-on training either with as an observer or on cadaveric workshops. Case selection strategies, I would say go with L4, 5, L5S1, contain disc initially because there is more wider interlaminar window and it is easier to do. Unilateral symptoms, no severe stenosis and no high BMI initially because in fatty patients it will be difficult for you to triangulate and it will be difficult. Measuring your curve, that's the standard thing. I'm just rushing through the slides, right, because we are already with the OT. And the most important thing is graph your learning curve. What I'm doing, how I'm doing, how much time I'm taking, so that needs to be taken care of. What gets measured improves. Analyzing complications during the curve, uretears, hematomas, and inadequate decompression are the most common complications which we encounter, and most of them are due to loss of orientation. Rule of thumb is frequent C-arm checking, and you should know where you are going. I would tell him, sir has already taken this slide. This is an important thing. Fixed workflow protocol has to be there. First of all, you should be docking the lamina, then clear soft tissue, identify spinal limited junction or C point, start drilling, expose ligamentum flavum, remove ligament, identify root, and remove disc. If you follow this set pattern, then you would be able to do the surgery in a more efficient and an easier way. Same sequence, every case, never jump a point. I will just flip through this video as well. Okay. Psychological barrier is 30% technical, 30% mental resistance, and summary and takeaways. Learning curve is real but short. Standardization reduces chaos, case selection determines success, measure of performance, and within 30-40 cases, significant OD time reduction will be there. UBE is not the future, as Sir has already said, it is the present, and we are all here to learn the same beautiful technique. Thank you.
Thank you, Dr. Bansal. That was a very appropriate talk to curtail apprehension of mobility weakness. And I think hearing such tips and tricks from somebody who has an experience, I've done a lot to our preparation and confidence. Back to
Sir, I have a question.
Yes, very good.
It's a very nice term, sir. I'm building it. Actually, it's a confidence who are building the UBE system right now. Especially the setting of monoportal endoscopy, learning the microportal endoscopy is very nice because we are very familiar with that as we are thinking every day of the procedure. So, by taking your steps, you can build a confidence of doing that. So, my question is, during the triangulation, if you are taking a standard points like standard incision and distance between the camera port and the working port. So is it varies with the patient, like if you have a big patient, 120 kg, 100 kg patient, and if you are operating a 30-40 kg patient. So will it be different in the triangulation in the cases?
It's simple physics. If you have, let's say, a high BMI patient, so the distance from the skin to lamina would be more, right? So the length of instruments which they would be traveling or traversing through the tissue would be more. So you need to have the distance between the upper more, let's say 3 centimeters. I use it more than normal patient. So I would increase to 3.5 kg. That's the difference. If it's a very lean patient and I can see that 3 centimeters enough. So that's the only difference, and you would get to know about it.
Thank you. In fact, we'll discuss all the questions in the lunch time because the OT is ready. We'll start the OT and then we'll have the next sessions. So I'll request our principal sir is here, Dr. B.K. Prashad. I was just telling in my welcome address that we are getting all the help from Dr. Prashad and Dr. our MS sir. So I'll request Dr. Prashad to please honor our guest. Thank you, sir. Thank you, Dr. Bansal. I'll request Dr. Rakesh, sir, to please come. Dr. Rakesh Singh to give token to our chairperson. Please come. Dr. Shuri. Dr. Shuri. Dr. Dhanvantri Shukla.
क्या करना अभी नहीं करना कुछ नहीं खड़े हैं दीदी हाँ उन्हें छोड़ दिया हाँ क्या करना
Dr. Amreen. Dr. Amreen. Thank you, Dr. Rakesh. Thank you, Dr. Amreen. Now we are going to the OT, and once we start, we find some time, we will have other sessions. Thank you.
नहीं आया कुछ नहीं आया कहीं और चले गए सब
It is like from 40, am I visible and audible there?
Yes. Mic.
कोई बात नहीं
It is like from 40,
Yes.
visible, audible and auditorium.
Yes, you are audible, Neeraj.
Sir, all okay?
Yeah, all okay.
So we are starting the case, sir. So coming to the fluoroscopic marking.
Can you just,
Put the
Neeraj, can you just show the scan first, Neeraj?
Yes, sir.
Because the people who have arrived later, like they will like to see the scan.
Okay, so I'll just put the scan also, sir. I'm just showing the patient position.
Okay, please, go ahead,
Zoom
go
out,
ahead.
zoom out, zoom out. Take from here. So slightly the leg end of the table has been kept down, so that Dr. Ashok suggests that we have to square the vertebra, and as an entry portal, all should be perpendicular to the target area. So when we have done this position, so this is the exactly what we are doing. So this is the marker that is exactly perpendicular to the L4 vertebra. So here he suggests that when we go towards the target region, our hands PIP में, मुझे PIP में
PIP पे डालो इसको, डॉक्टर नीरज।
हाँ, so yes, so इसमें what we are doing is this is squaring of vertebra. Our hand should not be like this; they should be perpendicular. So where there is a less chance to miss the target area. If we are slightly like this, then the problem comes. We are missing the target area L45. So this is what we are doing. After that, he has marked the midline and the target area, as you can see. Just hold on a second. We have just. So this is the midline. This is the midline part, and this is the horizontal marker that is just above the spinolaminar junction of the L4 L5 region. Spinal process in the midline, and if everyone can appreciate this window, this is the laminar window, interlaminar window. This is our target point. This is our horizontal marker. Now we are trying to mark the entry portal. So what he is trying to simulate with two needles, the triangulation towards this mountain, the spinopyramidal junction. So these are the two needles. He is trying to just simulate the portal position there to this point. Everything close to you? Done? So this is the AP view with all these needles. This is the pedicle. This is the pedicle. This needle is typically at the left spinolaminar junction. So for all those people who have joined later, just I'll give a brief overview of the patient here. So this is the MRI scan of the patient, 57-year-old male who presented with mild back pain and severe radicular pain to left lower limb more than right lower limb and neurogenic claudication. So this is the scan. The lateral scan is showing the severe canal stenosis and thickened ligamentum flavum. This thickened ligamentum flavum is causing the compression and the canal stenosis causing neurogenic claudication. The axial scan is here showing bilateral neural stenosis and the tripod sign, which is typical of the ligamentum flavum hypertrophy. So what we are planning, what the surgeon is planning is to dock on the L4, L5 lamina, and then Z pattern. In Z pattern, he has to excise the ligamentum flavum in toto. So we start from the ipsilateral upper margin, we go under the tape to the opposite margin, then come back to the ipsilateral superior facet, and then we go back to the opposite facet. This ligamentum flavum should be excised completely from foramen to foramen. That will only cause the relief of the symptoms of the patient. So the plan is for Z pattern decompression of the L45 vertebra standing on left side, L4, L5 UBE. So the incision has started over here. This is L5 pedicle there.
Once can you show the water,
Yes.
what is the height of water column?
Yeah,
This is
Neeraj,
Yes, sir.
they want to see the height, where the bottle is.
Sorry?
Height where the bottle is there.
Okay.
Just show them.
So the saline bottles are usually kept at the height of the head of the surgeon. So they can.
एक बार उसमें focus.
This is the height
Height
of the
of
surgeon. The
नीरज की
saline
height
bottle
के
is the
बराबर. नीरज की
level of my
height.
head. Yes, sir. Come back to the incision point. The incision typically is the stab incision. It should involve the facial cut also. The basic incision important there in UBE or endoscopic spine surgery is the stab incision should be deep enough to cut the fascia. First, it is cut along the line of the skin incision, and then a perpendicular T-shaped incision is given towards the medial part, so that it's easy for the scope to be manipulated. So the first dilator is going in to locate the spinolaminar junction on the ipsilateral side, that means the left side. This is totally a tactile feeling, totally a tactile feeling. You have to go along the lamina. The lamina will just guide you towards the spinolaminar junction medially and face it laterally. So this is totally a tactile thing. You have to first thing in UBE is go towards the spinolaminar junction. The dilators are being placed now seriously. So the first dilator should be very carefully held, because when you are putting the serial dilator, it slips and usually slips because this is landing on the most inferior margin of the lamina. So if there is a slight slip of this internal dilator, the thinnest dilator, it will go into the interlaminar space and you may have a dural breach at the initial part of the surgery itself, so you have to abandon the surgery. Steps should be clearly thought in your mind. These are the serial dilators going, and every dilator is going and hitting the spinolaminar junction. So this is the working port. It is the inferior port. Now a stab incision again, cranial side for the scope. Again, it's a complete. Ideally, the whole of the serrated edge of the blade goes in a moderately built person to cut the fascia. So there are two portals in biportal endoscopy, as the name suggests. The cranial part hold in the left hand is for the endoscope. The caudal part is for the instrumentation. Once triangulation is done and you have inserted the port, it typically behaves like a microscopic surgery, where left side you are holding the suction and right side you are holding the instrument for your work. The surgeon is now inserting the port with the trochanteric tissue for the endoscope. This is on the cranial end. The incision are around 0.3 to 0.4 centimeter in length. 1 centimeter away from the midline. Caudal pedicle, cranial pedicle are marked, and now he has created. The triangulation has been done. So he feels that the instrument have met at the spinolaminar junction. So the first step has been done. Now he creates a potential space, that is the song space. There is no cautery used here. no cough retractor, just the potential space which has the alveolar tissue has been retracted with the help of these two portal structures.
What about
We are
the
taking a shoot
needle shoot and
with these scopes in place to see the triangulation in a lateral view. EIP में स्लाइड पे see आपको. Okay. Now we are aiming towards the mountain. We have to land towards the mountain. So we are, the inferior port and the superior port have met at the spinal ulnar junction at the mountain. What we say, the Namaste sign in the traditional UBE teaching going on. So the target is L45 disc level, and we can see this portal is perpendicular. It is straight. We are not going down. We are not going up. We are just going directly towards the target area. Okay. Okay. So what the surgeon says is, if this angle is divided into two, so this is half of what above angle is. So your working portal will be better controlled and your viewing portal will be in better view and a wider view. This is your instrument port. This is your scope port. The instrument port is directly going towards it. So this is what the square motor vascular has been done. This enters in a perpendicular manner. The instrumentation becomes easy. Your hand becomes less fatigued because you are working in a lateral position rather than one place. The scope is in, you can see the bright red color of the blood. The second step of UBE after triangulation is to reach the spinal lamina bony margin with your scope in left hand and with the instrument in your right hand. UBE basically works on principle of continuous water flow from the cranial port and exit to the caudal port. Caudal port should show a fountain sign. The saline flow should be so adequate that the caudal port have a beautiful fountain coming out of the saline. So that is where we get the best vision during the biportal endoscopy. PIP surgeon's hand, PIP सर्जन के हैंड, हाँ PIP में सर्जन को देखना। हाँ, the camera focus should be done, the white balance should be done at the distance of 1 centimeter. Yes. Facing forward. The 30-degree camera, the endoscope should be facing forward as compared to the surgery. Needle. So I think we have a very good fountain of saline coming from the caudal pore, and we can start seeing RF. This is lamina that is visible here, the bony margin, and serious spurter can be seen through the lamina. The docking position is spinal lamina junction. Trace the whole lamina laterally. This is the RF probe, 90-degree RF probe. The right position of it. 90-degree RF probe, certified 2. 7. So this is where we are delineating the inferior margin of the helpful lamina. Bleeding can happen from 3 points. So 11 and 7 o'clock are one of the most common points of bleeders during this initial dissection part, delineation part.
नीरज,
Yes sir.
तो थोड़ा फोकस और करो कि क्या थोड़ा इधर जो आ रहा है उसमें इतना बढ़िया फोकस नहीं आ रहा है।
Camera का focus sir.
हाँ, कैमरे का फोकस।
That will happen so that will slowly it will be better.
Dr. Gaurav is appreciating your commentary. He's saying,
But sir थोड़ा सा loud थोड़ा सा बोलो पहले सर speaker बहुत कम volume पे है होती है.
okay, okay. हमने कहा कि Gaurav, Dr. Gaurav was appreciating your commentary.
Thank you sir. Actually वो सब आशुतोष सर ने पूरा script दिया हुआ है मुझे. So I'm just repeating that script only.
Okay, go ahead, excellent.
So this is the point where 7 o'clock position where the bleeders are usually seen. Now he is coming towards the facial part. Laterally, inferiorly. So you can see the RF probe is chordally. Intra-articular artery runs over the facet. This is one of the most common point of bleeding during our open surgeries also. When we are trying to delineate the facet and the transverse process, this is the way we get the major bleed. So there is the endoscopic surgery also. This the lamina has been placed very well here, as you can see. So on your screen, 12 o'clock is medial, 6 o'clock is lateral, 3 o'clock is inferior, 9 o'clock is superior. RF is working on the inferior lamina, the inferior lamina margin of the L4 vertebra. This is the medial part, the spinous process. The spinous process has been denuded here. The process has been done. we are not using any cellular retractor. We can show it on the PIC screen. Code becomes very even slow. Usually the cellular retractor is not used at all. Sometimes your triangulation is little bit problematic and your water flow is not good. Your vision gets hindered. That is where the cellular retractor comes into place. We need good outflow to see good image inside. You can use the cellular retractor intermittently. Cellular retractor default.
Now we can see the hand movement in PIP.
The cellular retractor. Yeah, this is the cellular retractor. We are following the root of the spinal process is distributed. This arch of the spinal, the lamina is followed medially, and this is the root of the spinal process, the bulging middlemost part, this bony part on which the RF probe is working. Finding the interspinal filament and going through a root of the spinal cord. This is the root of the spinal cord that is at the 12 o'clock position. Down in the depth we can see the yellow ligament, the ligament of
Focus. 10-4.
We are working laterally. All faculty just have to take because the most difficult part as a viewer in this surgery is what are we working on. So this is lateral. 6 o'clock is lateral position. We are working on the physical area. The lateral aspect of the ligament of the So as I told, the doctor is doing the phlebotomy in a Z manner. We are starting on the superior attachment ipsilateral side, going to the opposite side of the superior, then coming back to the inferior superior facet, and then going back to the opposite side. UBE water-based system, if there is light bleeding, just hold on for a second because the water flow will clear it off. Try to find that bleeder. Usually you can easily control the bleeding. Slowly go towards that bleeder point. Wait there. Let the soil wash it out. Then you will be able to see the bleeder very well. Removed in this UBE circle. Small muscles at the lateral margin of the facial-laminar junction are the rotator muscles. Inferior lamina. So 3 o'clock, Dr. Ashutosh has felt the inferior lamina. Artery, the artery. No, just go. you can appreciate slight blurring of vision. The cause is saline equation is incomplete. Always, this happens throughout the surgery. You can always go in with the dilate the tract again. Do not increase the water pressure. That is the thing we don't have to do. Go dilate again. Your vision will definitely improve as the saline equation improves. Muscular, yes. So this is actually a muscular band. So that the port closes during the removal or the change of the instrument. So we can always use the dilators again, establish the saline outflow, and your vision will improve. So we are back to the SD vision here. So this is the alveolar fat. We can see the canalicular fat. You can easily differentiate between the fat, ligamentum flavum, muscle. In this picture, you can easily differentiate. The ligamentum flavum has started coming. And that's the laminar phase at the center of the screen. As we go deep down, the RF setting will slightly go on decreasing. So, this is 70. So, when we are working near the bone, the RF setting was 9 ablation and 5 coagulation. Now we are going below the lamina. So, our RF has changed from 7 to 3. We will efficiently go to 5-2 or 3-2 also when we start seeing or working around the tumor. So this is the constant thing we have to do during the surgery as we are going deep towards the neural structure. The RF power should be released. This is again 12 o'clock position medially towards the spinal process base. For the lower interspinous ligament can be seen between the two spinous processes. So he is working on the superficial part of the ligamentum flavum. So during UBE surgery only we have learned. Actually, I learned that ligamentum flavum has two parts, superficial part and deep part, and we remove that layer. So during the microscopic surgery, we are not used to do that. We are seeing that interligamental phase, what are cut and slide go with complete one micrometer. Here we are able to see the superficial layer, the deep layer of the ligamental flavum. First step was triangulation. Second was delineating the bony landmark completely, the spinous process at the 12 o'clock position, the facet at the 6 o'clock position, interspinous space at the 3 o'clock position, and the lamina at the 9 o'clock position. Now we have to start bony work. That is also over. That is also over. Patient must submit. 70 cents. Inferior lamina can be easily appreciated and the attachment of the ligamentum flavum. Now the RF is used to coagulate that attachment. To create the space between the bone and the ligamentum. Two pressure. Yes.
Neeraj,
Yes, sir.
what is the ablation and coagulation at present?
Ablation elevation formation is currently 7.3.
Okay.
Now we are starting to use the drill to do the bony part. So as said, the Z pattern ipsilateral drilling will be done to delineate the superior attachment of the ligamentum flavum on the ipsilateral side. So the surgeon will be starting laterally, going towards medial root of the spinous process. The aim is to delineate the origin of the ligamentum flavum superior.
Neeraj,
नीरज डाल के रखो ना।
Neeraj,
Sir.
yeah, normally we drill from medial to lateral in microscopy.
Yes, sir.
So, like, doctor,
Actually, it totally depends on the surgeon's preference.
okay,
So, Dr. Ashosh is doing from, because he has marked a well-marked groove over the spinal junction.
Okay.
So, he's starting from lateral towards the medial, because this is a canal stenosis. So, actually, we have to work towards the medial part also.
Right.
So, he has to drill the base of the spinous process, go on the opposite side.
Okay.
And to the opposite side, you will come not to. So, especially when we are doing this, we will come from medial to lateral, minimum of the facet dissection, so that we can find the lateral attachment of the ligamentum flavum. We can make a split there from the superior end, and we can remove the disc. But here we have to remove the complete ligamentum flavum. So the drilling has to be either medially to laterally, but the whole ligamentum flavum attachment has to be deleted.
Dr. Rakesh has got some question. Good morning, Neeraj.
Sir, good morning, sir.
Tell us, viewers, that when you are using cutting drill and when, at what time you are using this diamond drill?
Actually, Mr. Dr. Ashosh here is using the diamond drill from the starting itself.
Okay.
He has asked for a non-bullet drill, but what we as beginners we are not very confident enough to protect the dura. So we are using the wooded burr. But when we are doing the cortical part of the bone, the initial drilling, we are using the cutting burr. And as we go deep, the thin part of the bone is left near the dura. We use the diamond drill. The thing is, diamond drill will give you precise and slow cutting, and the cutting drill will give you big chunks of the bone removed in a short time. So when we are doing the superficial part of the bone, the thick part of the bone, the cortical part of the bone, we are using the cutting burr, and when we are using for the thin bone overlying the ligamentum flavum, slide over the dura, thinned out facet, we can always use the cutting burr that is little bit safer while working near the dual structures or the dual.
So tell us, what is the setting of drill right now for diamond drill? Means I want to ask RPM.
So he is using at around 16,000 to 24,000 RPM.
And for,
This is the cortical layer that is delineated.
for cutting drill, what RPM you are using?
Sorry, sir.
When you are using cutting drill,
Yes,
then
sir.
what RPM? At what RPM?
So we can go up to 30,000 RPM by using the cutting tool. We can easily know cortical layer of the bone. This SD vision will give you very good vision that what are we actually removing. So we can easily see the cave is increasing. Now the deep bone part. That is where this diamond becomes very helpful.
Yeah, we will appreciate.
Slowly. Sir, sorry.
We are able to appreciate. Yeah.
Sir?
Yeah, we are able to appreciate, Neeraj.
Yes, sir. So, RF. So we can just remove this overhanging part. This is in the midline. These are base of the spinous process. You can now very clearly appreciate the base of the spinous process. The spinous process, a cave or window being made from the inferior lamina going superiorly towards 9 o'clock position. And I can see towards the root of the spinous process. Now we will be starting this. Yes, this is the root of the spinous process. When you are removing this extruded fragment, parasegment this, usually we don't want this immediately. But again, we have started with a little bit difficult surgery here in the program, the canal stenosis. The canal stenosis demands removal of this spinous process. If we go under the spinous process towards the opposite side. Again, the thing that we are always aiming is remove the ligamentum flavum in toto. From edge to opposite edge. Free the foramen. Especially because the symptomatic side here is left side, we are starting on left side. Right side also will be decompressed for the future purposes. And adequate ligamentum flavum excision with, if required, physical drilling to free the exiting nerve root will be done. It all depends upon how well are you reading the MRI. So here is MRI showing only ligamental hypertrophy, even 5 physical hypertrophy. As soon as you release this thickened ligamental flavum, we will be able to see the exiting nerve root very easily.
Dr. Neeraj,
Sir,
can you tell viewers about safe drilling techniques? Like it is one of the most dangerous systems in during endoscopic surgery, and also one fact is important here that when surgeon start drilling, then vision is blurred because of dust particles.
yes sir.
So tell us preventive measures for neural structures.
Sorry, I'll just come back to you. This is the white line what Dr. Ashok is trying to say. Ligamentum flavum is white here. Attachment of the ligamentum flavum can be appreciated with this white line just under the burr. We can now see small vasculature also. So I think everyone is able to appreciate that, right?
Yes, yes.
That is the upper attachment of the ligamentum flavum. So coming back to the question, sir, usually during the drilling, the two most common things which we face is the hindrance of the vision due to the bubbles or due to the bone dust. And you can do nothing, sir. You have to just wait. The water flow will clear everything off. Drilling process should be always intermittent and not only visual based. It is tactile based drilling. Your drill is always on bone and then only it is switched on. Yes. So now you can see. So Dr. Ashok saying we are not able to see any bone dust now because we have reached the cortical bone here. It is only at the superficial part, the hard bone part where you see the bone dust. And I have encountered so many times, and when I saw Dr. O.P. Singh telling us how to clear the bubbles, is just to wait. In one of his videos I have attended, and he just told, just wait, everything will clear off with the saline. Now we are going towards the base of the spinous process here. You can see the ligamentum flavum bulge coming on. He is intermittently pushing it down with the help of drill only, not switching on, but just using as a distractor.
Dr. Neeraj, we need one more time orientation.
One more time orientation. Okay, sir. So this is
Please orient us.
spinal laminar junction.
Yes.
This is the 9 of this is 12 o'clock position medially, 6 o'clock position laterally. This is inferior lamina, 3 o'clock position, and on the 9 o'clock is the border. The border we are going drilling and reach the attachment, the upper margin of the ligamentum flavum. This drilling is going on the base of the spinous process, medially. I think slight part of the ligamentum flavum is occupied. this is typically ligament of flavum only. It is occupied, that's why. And now diamond work is working wonderfully. We cannot work here with a cutting blade. It will definitely lead to a dural case. We can easily see the margin of the thin bone here. Now we are putting the dissector here to delineate the inferior margin of this thin bone. Yes, now we can see. This is the superficial ligamentum layer that is slightly calcified. Now we can put in a upcut punch.
Excellent demonstration, Dr. Ashutosh.
He says thank you. He says thank you to all the faculties. So typically he said during the beginning to tell you at this point. During UBE, the midline flaval junction is the safest point to put the upcut. Before that, don't put the upcut. So till you find the mid, now you can easily see the dura. I think everyone can appreciate the dura here.
Yes,
Window.
laterally.
So always look for the median ligamentum flavum junction. Here you have the straight also. Always go in the median most part of the ligamentum flavum. Here you have a natural split, number one. Number two, the fat is maximum, so you are well away from the dura. There are least chances of dural tear during putting the upcut punch here. Never ever try to start your ligamentum flavectomy laterally. Where the attachment is very dense and the dura is very close contact with the ligamentum flavum. Now here you can see easily, there is so lot of space, normal upcut. There is no need for any special calycer counters also here. A normal calycer counter is able to remove this thin chips of bone here. And it is the edge of the ligamentum flavum, the calcified ligamentum flavum. You can see the fibers going up. The direction of the calycer counter is pointing towards the direction of the ligamentum flavum fiber. Now this is lateral cut. This is towards the spinophysical junction. So we have started the Z point. Now we have started to make a Z here. Upper edge. Yeah. So starting the Z from the ipsilateral side, upper edge. Now we will follow the upper edge to the contralateral side of the ligamentum flavum. The upper limb of the Z. Again, so slightly blurring of vision. Wait. It will definitely, your saline flow is good. It will definitely improve your vision. Usually in this, you don't have to do this much of body work. So this much of vision problem will not happen in the disc. But in canal stenosis, it's a tedious job. Lot of body work, lot of drilling, lot of stopping, lot of dissection. So it requires time, and UBE definitely requires time in your first 25 cases. If you don't have time, please don't do UBE on that case. If you are starting a UBE case. So what we have started is, if we are doing a UBE, we will not entertain OPD after the UBE. We will not entertain emergency during that surgery, because that requires time. The previous retractor will go there. Now we are going toward the opposite side, under the cave, and this is the opposite, I think, of the ligamentum flavum. Contralateral lamina is exposed. Contralateral lamina. You can see we can go, we are going under the cave now. Taking the ligamentum flavum from the bone. This maneuver requires slight hand positioning and awkward instrumentation, because this is looking easier on the screen, but definitely it is a difficult job to put an instrument and orient in that direction to do a upcut. रिपीटेड फेलियर्स होंगे इसमें, रिपीटेडली आप इंस्ट्रूमेंट डालेंगे, आप कर नहीं पाएंगे, या फिर आपको ट्रेन करना पड़ेगा. इट विल गो ऑन till you find one that point where upcut lands beautifully, और फिर सब जल्दी upcut करेंगे. It's doing on tactile basis. Yes. So root of the side process is calling the hindrance to put an instrument there. Now we go from superficial to deep, drilling towards the spinous process. This is totally tactile based. He's on the bone, he's yes. The surgeon says that as we going on the contralateral side, the vision will be hampered more. The natural flow of the slide, it becomes hampered. That's why vision will get. So always, the only suggestion that the surgeon gives is hit, vision improve करेंगे, फिर आगे बढ़ेंगे. Wait करेंगे, vision improve करेंगे, फिर आगे बढ़ेंगे. Ligament of plate. Ligament of plate is actually acting like a cushion to prevent the dura of the RF. Yes, this you can appreciate the epidural fat now. So now we are near the dura. We are going away from the dura again. Inferiorly, this is the inferior part. The opposite part, the RF is directed medially. 12 o'clock is medially. Now I think you have created a very good cleft as everyone can appreciate. And we can put an instrument or a drill there. Remove this overhanging spinous process. This is the overhanging spinous process. So this actually hinders the vision and the entry of the instrument also to the opposite side.
Neeraj,
Sir,
he is pushing the drill towards the, the upside, like towards the sky maybe, towards the base of the spinous process.
yes.
And the pressure is, I think, the base, no?
No. The drill is starting from the base and going superficially.
That's what.
The drill pressure is away from the dura.
Yeah, from
So there is
below.
no chance of slippage only.
Yeah, below.
Yes.
Yeah.
The direction of the drill, the pressure he is applying towards the skin, I think. Towards the skin. If we do the drill downward, then there is a high chance of dural tear. So he is going inside and he is bringing the drill superficially. He'll demonstrate what he is exactly doing.
Inside to outside.
He is coming up. He is starting down, he is coming up. I think you have got that point where we can use the upcuts now. We are going to the opposite lamina. This is lamina on the opposite side. He is taking cut. This is the base of the spinous process now. It has been completely removed. Now we can see the complete laminar space as we see in the X-ray. The shape looks exactly, it looks in the X-ray. Going to the contralateral side. This is around 10 o'clock is the superior side. This is the ligamental plevum. He is removing the superficial layer. It will start for its complete. Here the front palm. 90 degrees. straight and straight. So you don't use that at all. Oh. Okay. So this is actually a beauty of UBE. You can start really with minimum of the instruments there. Huh. Huh. So the live Dr. Ashok wants to convey to the faculty and the delegates there. UBE is such technique which uses a minimal number of instruments but provides a comprehensive spine decompression. There is no compromise in spine decompression there. And we can use the minimal number of instruments, the open instrument maximum. So that's why he's not using the straight RF. He's saying a single right angle RF is enough throughout the decompression surgery also. Conflict of interest. Bonds may not sponsor this statement from us. Epidural rates usually bleed from the normal microscopic laminating. Also, we'll see the bleeding from there. So now when we are putting the instruments currently, you see we are going straight towards 12 o'clock. Now suddenly we change the direction towards 1 o'clock. Because now the direction of the lamina towards the patient of the opposite side we are going. We are trying to contralateral lamina under surface. Yes. Yes. The fact you can see the foam-like structures for the first time our MBBS students, PG students, this is fat, the epidural fat. This is not good. Actually, as a surgeon, we don't want to see this. Try to avoid this. Stay away from this, stay above of this. He is now drilling medially to lateral. Above the ligamentum flexor, not above the fat. Fat is in the midline. He is working above the ligamentum flexor. The scope is going towards the opposite side. And now enter the cave. Same thing. Now we are going towards.
Dr. Gaurav wants to ask something. Comment.
Sir?
Dr. Neeraj, we are not using any chisel so far. Won't that make the thing easier and faster and better? What's your experience? Chisels.
I think that there are literally two schools of thought here. Chisel makes your life easier. Chisel gives chances of pressure or injury to neural structures. Definitely, chisel is one of the most commonly used now because of the faster thing and minimal drilling part when you have cut down. But Dr. Ashok here suggests that he doesn't usually prefers chisel hammer here. He wants to do it slowly and beautifully here without giving undue pressure, any kind of pressure to the neural structure. But what we are also doing, sir, when the facet is a little bit tough to drill, we use the chisel. It definitely reduces the time of the surgery. This unnecessary drilling part when the facet is here, the facet is behaving very beautifully with the diamond drill also. So I think there is no use of chisel here. If it would have been difficult and sometimes we would have felt the using of cutting burr, then definitely chisel plays a very good part.
See, I have a comment. I'm Singhania. Chisel is good for
This bleeding
undercutting.
is from the bone.
For
Do
undercutting.
not
it's-
coagulate it. Use a ablation for it.
See,
This is completed. So what Dr. Ashok has said, bone bleeding after drilling underneath the bone is to be ablated for better hemostatic control rather than causal. And sir, finally I want to say chisel plays a very big role during the fusion surgery. We get a very good bone chunk for our implants. So whenever we are planning to do a fusion surgery, then we should definitely use chisel. We get a good chunk of bone for adequate fusion. Otherwise, chisel is literally depends on the surgeon's choice. I don't think कि जो सर्जन यूज कर रहा है उसने कभी यूजर स्ट्रक्चर को हिट भी किया होगा. There is always a personal preference to use a drill or a chisel during doing the bone work.
so see, there are two things. One is.
Sir, आवाज थोड़ा सा.
Oh, sir, okay.
हाँ.
So see, there are two things. One thing is how you are comfortable with the handling instrument.
Yes, sir.
So if you are comfortable with the chisel, you can. If you are with the drill, you can.
Yes, sir.
But I will tell you regarding the chisel because it's a good thing for undercutting the lamina. If you are slightly angled and cutting it, it's easily you can remove the undercutting chunk of the lamina.
Okay, sir.
And your life will be much easier than drill. What I will say.
Definitely.
And
If
what,
we are comfortable with the chisel, it will make our life much more easier.
yeah, the second thing is regarding the what you are telling the mechanical injury due to the chisel. So
Sorry, sir, if I interrupt you, just we are demonstrating the inferior margin of the ligamentum flavor, how it inserts on the caudal lamina. Caudal lamina. This is the insertion of the superficial part of the ligamentum flavor. So we are just trying to drill a small part of the caudal lamina so that the insertion of this ligamentum flavor can be excised. This is, we are working on the caudal lamina. The caudal lamina. Here the drilling is not more extensive drilling, only to remove this attachment of the ligamentum flavor. Again, we go to the first slide. The main goal is in total phlebotomy. Any phlegm left will cause recurrent symptoms. So the inferior part of the lamina here is drilled with the help of a diamond burr. It will detach.
Leaders,
Sir.
I am noticing that whenever there is a slight bleeding,
Yes, sir.
Dr. Astosh is nicely using that Hafida and is always putting his direction upwards.
Yes.
And whatever epidural is there is coming and he is able to coagulate. That is
Yes.
one of
I
the.
also learned this the same thing from there. He is using it so brilliantly.
Yeah, we are having issues. It takes time and then we change to the other one.
The state, the 90 and the state RF.
Yeah.
Definitely. So I would like to tell everyone that Alopuja sir refers to 90-degree RF as the Hatida. It looks like the हाथी के पैर जो होते हैं, तो we don't use it 90-degree RF. हम लोग अपने टेक्नीशियन को ये बोलते हैं कि हाथी का पैर वाला लेके आओ. So we have to use it upward serrations. That's how today Dr. Ashutosh has shown us and taught us there to control the bleeding without any injury to the underlying fever.
And that was his nice. Till now, everybody is watching very patiently, and everybody is very involved in this thing. He's got good hand, and this coagulation
really
technique.
going very well here.
Yeah, excellent. That's good.
So we can see, appreciate the three parts of the inferior lamina: cortex, cancellous bone, and the cortical bone again. So now we are separating the superficial part of the lamina, inferior attachment here, from the caudal lamina. Ligamentum flavor. This is the inferior attachment of the ligamentum flavor from the caudal lamina. superficial part of the ligamental flavum is around 3.5 mm thick, and the deep part, the thick part is 1 mm only, the deep layer. So when we remove the superficial part, we'll get an extra 3.5 mm space here for working during the UBE surgery. So we can now see yellow, more darker, dark yellow is the deeper part, superficial part is little bit whiter. Everyone appreciates, I think. This is the yellow part, that is the deeper layer of ligamentum flavum. This is the white part, that is the superficial layer of the ligamentum flavum.
Well appreciated from here.
Inferior facet, superior facet. The lateral attachment to the inferior side. Now the Z has come from horizontal slanting away to the ipsilateral side again.
Dr. Neeraj, which drill system you are using in this case?
So we are using complete bonds system for this RF drill system, cameras, light source also. A complete tower of bonds. This is the plane that has been delineated between the superficial layer and the deep layer of the ligamentum. Currently we are using a semilunar refractor here. Muscles are a little bit stiff, if you focus on semilunar refractor showing a very good fountain over here, and you can see the PIP. Ligamentum, this is the superficial layer of the ligamentum flavum that has been removed. Now the working space has increased to a great amount here after the superficial layer.
Yeah,
Dr.
good,
has just
good flow
demonstrated.
of water, good flow.
Actually, he has demonstrated. Ideally, he says that he removes it completely without deleting all these things. But for the audience, he has demonstrated the superficial layer. Now he will be working on the deeper layer. This is the median cleft of the ligamentum flavum. He's putting the, so always try to put your upper trounger in the middle cleft. Here you get the maximum distance away from the knee. Least chance of the ligamentum flavum. Here, what we are working is the inferior attachment of the deep layer. This is the most common site of dural tear. Here you have to be very particular. Dissect it off. Junction of the laminal lamina with the facetal junction is also the junction is the landmark of the traversing nerve root. Here, and you can see the surgeon becomes a little bit slow to ideally delineate the complete structure slowly bit by bit. This is the superior border of the caudal lamina along with the deeper layer of the ligamentum flemoris excising. Now he is going towards the facet, the laminofacial junction. This is a safe zone. You can see the rounder has been held in the reverse manner. Ideally we have the rotatable rounders also in the set. But he is using as a, because as you can say, we have to demonstrate UBE as a minimalistic but comprehensive surgery. So no use of rotatable rounders there. Yes. Crucial layer of the ligamentum flemoris is ablating it. In the picture you can see it is the caudal lamina. Now we are going the Z, the last transverse base of the Z. We are going towards the opposite side along the inferior margin of the ligamentum flemoris. Thin membrane like that. The ligamentum flemoris directly it is not attaching to the inferior margin. You can see a thin membrane here. He is trying to demonstrate the thin membrane through which the ligamentum flemoris attaches. Yes, this thin layer is the attachment of the ligamentum flemoris to the caudal lamina, and later it becomes the facetal capsule. So yes, this membrane can be very now it has been torn. Everyone can appreciate, I think the membrane has been torn through which the ligamentum flemoris has attached to the caudal lamina.
Yeah. Clearly seen.
The Francois is working to just bring it to the regulation by his name here. He'll be naming it soon, this membrane. Interspace. contralateral. So we are taking the base of the Z. We are going along the lower border of the ligamentum flavum on the contralateral side. So the 12 o'clock is now the contralateral side of the spinal cord from midline to left. Let's see the cancellous bone of the caudal lamina.
Neeraj,
Sir.
base of the Z on ipsilateral is done.
Yes, sir.
That is done, no? So
Base
that,
of the Z on
and-
the ipsilateral is done.
Yeah,
Now
now
we are
on the
going
midline.
on the contralateral side.
and
The
ipsi,
position is the contralateral side.
yeah, and ipsilateral was the your membrane, right?
Yes, they remove the membrane.
Okay.
Actually, the drill bit is landing on the ligamentum flavum, not landing on the dura.
अब पंद्रह के हो ही जाएगा जब
Superior patient is coming, now on the contralateral side. And then you can appreciate the direction is changing, the bone direction changing superior. This diamond ball can be used as a hemostatic. So he has used that as a hemostatic agent for bone lesions. You can see the full facet, superior facet of the inferior vertebral body.
This is on the opposite side.
On the opposite side.
Right. He is using drill as a dissector also.
The government of Taiwan is giving very good question.
Shrinking the ligamentum flavum, I suppose.
You'll be using the RF to detect the superficial layer of the ligamentum flavum from the deep part, and it will be able to go superficially. So the dura is lying down, so there is hardly any chance of the dura injury with the RF. It's going from down towards the skin. Safe area, because dura is lying downwards.
And it is making the ligamentum flavum, the superficial part, a little bit shrinking also.
Yes, it is shrinking. this detachment is for the interspine ligament here detachment. Fine. Okay. Next case will be using the general neurosurgery instruments also with that. So maybe that will tell you the difference. The next surgeon. Because definitely this instrument that has come with the system is little bit heavier than we are used to.
See a little bit of last part.
No, we are continuing with the last part.
Yeah.
We'll just want Dr. Nikunjogi to just acclimatize to the OT.
Okay.
And, we can just start with the induction part.
Okay,
And
so
we
that-
will complete this case, no problem.
Yeah,
There is
yeah,
no interruption in this relation
So-
with the last part of the segment.
So you want Dr. Nikunj to...
Dr. Nikunj with Dr. Rohit, Nikhil will accompany them to
Okay.
come to the OT.
Okay. Nikhil?
This is the foraminal part of the ligamentum flavum. Just under this upcut is the gel. And it is visible without any refraction just because of the 30-degree camera we are using. The 30-degree scope we are using. Good afternoon, Dr. Karthikeyan. We are really esteemed to have your presence here. We are really happy you can join us and give us your insight over endoscopic spine surgery. Greetings from Dr. Ashutosh Kumar sir, UBE Ashram.
Excellent demonstration.
This is the part of the ligamentum flavum that goes along the exiting nerve root. Now you can see that the pyramid has gone towards the sixth of position to see the contralateral. It remains the same. For the viewers, it remains the same. But for holding the scope, it becomes a little bit easier. And to manipulate the scope for the surgeon. So again, the 12 o'clock position becomes the contralateral side. This is the jugal step. No fat. There we can see appreciate a good amount of fat there. So here the compression is a little bit less as compared to the left side. We are removing the ligamentum flavum and last part, exiting nerve root part. Complete the foramen is required. Contralateral side. This is the contralateral side. Again, this is a bony sheet. Do not forget. Update it. Better you just control it. Contralateral side again, the exiting nerve root takes away the attachment of the ligamentum flavum along with it. You have to make that attachment also. Just seeing that little most part of the ligamentum flavum.
फिर उसके बाद इसने निज़ाम चेंज कर लिया बहुत सारा निज़ाम क्या है और फिर जो हमारा एक वो था हमारा पीछे लेवल में तो मेरा भाई
Interior part, control electrified. Almost done. Almost done here. To the last part of the number 5. Just about to fly. That actually everyone must have observed. There is no continuous burst of the RF by Dr. Ashutosh here. It fires for 3 to 4 seconds, it stops. I think the RF should be used in a similar manner. It increases the life also of this RF and prevents unnecessary damage to the nearby system.
And still the ablation and this thing is 7.3?
No, sir. When we are near the structure, it is 5-3.
5.3, yeah. Oh.
Though recommendation is 3-2, but since he is going away from the structure, the direction of the RF probe is upward, so he is using it 5. But while working near the structure, the recommendation is to use the setting of 3-2. 3 for ablation and 2 for coagulation. The last lateral attachment of the ligamentum flavum on the contralateral side. Feed the contralateral traversing nerve. The last part of the therapy.
What is the size of Garrison you are using?
Yes. Which number of Garrison he is using?
So number 2 and number 3 only he has used.
Number 2 and 3. Okay.
He has not used the smaller one. And still he is saying that we should use the normal general neurosurgery patient lounger rather than this bulky, because it is causing some hindrance while passing to the foot. These are the rotatable patient loungers that have some spring mechanisms and all. So that was slightly obstruction while inserting and coming out of the foot.
Right.
We also face the same problem, sir.
Yeah.
We also like to use the general surgery one number two, general neurosurgery one and number 2 number.
Correct. So curve one is difficult to put, and again you are lost sometimes.
last part can be done with the upper itself, that is last superior attachment on the contralateral side. I think he's working on the shoulder of the root. Now we can see the ligamentum flavum is completely detached from all the attachments all around. Only the midline attachment is there to the dura.
Dr. Neeraj, please make us orientation.
The orientation again, sir. The 12 o'clock position is towards the midline. The 9 o'clock position is superior. 3 o'clock position is inferior. We are actually working bang on central in the lumbar canal now. We are removing the central part of the ligamentum flavum.
Okay.
This is the dural sac we can see.
Yeah.
The butterfly is just about to come out with the attachments all around, and we can see in the focus. Now the PIP picture will show you the focus of the butterfly that has come out. Sandeep, can you hold it in your hand? Now show focus.
It's a big size.
Near perfect butterfly.
Yeah. It's not audible, not audible.
We are actually shrinking this first can be seen easily, but there is no another clear. The basic pathology here was lumbar canal stenosis due to ligamentum flavum hypertrophy. So instead of unnecessarily opening the disc, Dr. Ashutosh is here shrinking the disc, what we call as angioplasty using the RF probe. The root is already decompressed. The basic pathology, the dural surround knotting has been done. The dural sac is pulsating very well after the decompression. You can see all the four corners of the canal after removing the butterfly flavor. This is the last part. This is the SAP, where you can see a blood clot there. That is the SAP.
What about the roots, sir?
This is the root only, sir. This is the root. This is the fetal sac.
Yeah.
This is the root.
Oh, yeah. It's okay.
This is the root, and this
It's
is the
okay.
axilla of the root.
Yeah.
And this is the SCP that has been small drilled part tip of the SCP that has been drilled. The left root is very well decompressed over here. Now we rotate the is using 30 minutes. You also is the other very comfortable. Yes, sir.
So are you seeing the foraminal patency? Are you seeing the foraminal patency, especially the upper foramen?
Sorry, sir, we are not able to hear you.
Foraminal patency, especially the upper foramen.
Upper foramen.
Yes. By inserting some instrument to look whether your foramen is free
That
or
is the
not.
basic thing that is always left and cause of a residual symptom or recurrent symptom. So that is where the ligamentum flavum is detached while it is going up in the foramen. So as you have seen when we are doing the Z pattern, the upper margin was placed towards the contralateral side. That was the upper foramen from where the ligamentum flavum was removed and excised. So always there is a agent of formal usually remove the tip of the SCP and that if the CT and MRI shows that the bony part that is causing
Voice is very low, Dr. Neeraj. Your voice is very low.
this is the contralateral disc that can be seen. So this is over the contralaterally also we can approach the foraminal extraforaminal disc from the left side standing position which we are saying. This is the SAP on the contralateral side. So that body part is the interior. And if we are removing this ligamentum flavum which is between, there lies the SAP on the contralateral side. I think the decompression is very well done here, and it is from the delay for the surgery for this patient. Thanks to Dr. Ashutosh here for demonstrating it so beautifully and so nearly perfectly how to do a lumbar canal stenosis and also pregnancy. So back to Alok sir. Back to Alok sir.
Hello.
Sir, we are completing over here.
Right.
Sir, and we can start with the platform session, so we prepare for the second group.
Sure.
And we can see the root on both the sides.
Right.
The dual sac has been adequately decompressed. This is the contralateral side. This is the contralateral side.
Yes.
Inferior facet, the contractor is demonstrating the contralateral side of inferior facet. To the superior article. It is being developed just over the superior article. The part of the development that is developed. As the patient does not have right, there is no failure.
Okay. Mainly it is on the left side. And canal claudication symptoms. Right. So thank you, Dr. Ashutosh, and I think he need a big this thing of applause. Thank you for very nice display. Now we are switching over to the lecture so that we can do all the cases in time. Thank you, Dr. Ashutosh.
Dr. Ashutosh, thanks everyone for their peace and patient listening.
No, it was very sort of mesmerizing, like everybody was silent and focused. That is the
Literally
beauty.
it was like that from here also, sir.
Now people are going for the coffee.
We can start with the platform presentation. We are taking
Yes. Oh, okay.
15-20 minutes will be back with you.
Sure. Okay, by audio visual, we can start. You can switch over to the. We are starting the lecture session, which was left. So we'll be next presenter. I will call the chairperson first. I'll call Dr. Sandeep Rai and I'll call Dr. A.K. Mishra, because we are having right now this thing, because Dr. Nekunj is in OT, so his lecture will be later on. Maybe we'll have one lecture and maybe another one time permits. So Dr. Sandeep and Dr. A.K. Mishra from Faizabad. Dr. Sandeep is a senior neurosurgeon from Varanasi. He has got his own clinic and he is working in Oriana Hospital. Dr. A.K. Mishra is from Faizabad, Ayodhya now, and your hospital name is Agrim, another Agrim. So one Agrim is in Varanasi, another Agrim is in Ayodhya.
One in Gurgaon.
One Agrim in Gurgaon. All right, great. So I'll call upon Dr. Arvind. He is from AIMS Raebareli. Please come for your lecture, that is midline biportal endoscopy for lumbar canal stenosis. Over to Dr. Arvind.
चलेगा नहीं कुछ दिखाने के इसमें नहीं कुछ दिखाना पीपीटी चलेगा ना नहीं दिखेगा जला ही नहीं जाता
After such a wonderful surgical demonstration by Dr. Astos, I don't think any need is there for me to explain anything about UBE, but I will try to do the justice. So I'll be presenting my talk on midline biportal, just a little different from the usual biportal in the entry only, but the mother is UBE only, so don't consider it as a separate different surgery. Something about the history. UBE is minimally invasive surgery. In 1990, first microscopic discectomy was done. In 2000, biportal technique was introduced mainly in Korea, then propagated in the world. And then there is rapid global adaptation because this technique gives you familiar anatomy. You get a very good visualization compared to the open or a microscopic technique. And you can use conventional instruments of your open set of open spine surgery, but for doing UBE. So you don't need a expensive setup. So if I introduce you, this must have been the introductory lecture. So here, as Dr. Astos has already said, this cranial side, we use the scope through which we are seeing the surgical area. The scope can be of 0 degree or 30 degree. It's the surgeon's choice. And if we use a working port corded to the camera port. So if you are a right-handed surgeon, you always operate from the right side. So we prefer to stand on the left side of the patient, and this ergonomic comes. So there are two independent ports, you can see cranial and caudal, and it's like doing the open surgery or microscopic surgery, just your visualization is changed from microscope to the endoscope. And basic principle through which UBE originated is the Son space. So if you can appreciate, there is a potential space. It's not good. Is it visible there? Okay. So this potential space, if you can appreciate, between the multifidus muscle and the bone is known as on space. The alveolar area, which we discussed in the presentation. So as soon as you put the water column there, through the water pressure, this space opens up and you create the working space. Like you put CO2 in the abdomen and create working space. Here there is no space, but the potential space which has been created, and then you start drilling your lamina. So because the two ports are there, primary thing is to do triangulation. So here I want to specify, when we do midline UBE, the triangulation is very easy. We do triangulate it like monoportal. And continuous irrigation gives us very good visualization, muscle splitting approach taken so that no muscle fiber is damaged, and we remove very minimal bone. Because we remove so much minimal bone during this, the preservation of stability is there in the decompression. So if I talk about triangulation, so if you triangulate it wrong, like this is open triangulation, you will miss your instrument when you will be seeing from the camera angle. Normal triangulation should be like this, the middle picture, where your camera should be clearly seeing your working instrument at the very point. And if you ugly triangulate it, this picture will be there. There also you will miss the plane. So triangulation is very important for starting the UV. Because if you cannot see your working instrument through your camera port, that job is very difficult to do. So I'll brief about the equipments. There are 0 or 30-degree scopes, light source and camera as we use in the laparoscopic surgery. Saline irrigation pump, which we have seen in the surgical demonstration already. There's one thing I want to emphasize. You can also use TURP pump or something to put pressure when there is bleeding, but it should not be more than 30 to 40 millimeter of water. So RF ablator can be used. Settings have already been discussed. Kerosene punches can be used from the normal set only, and high speed drill, whatever you are comfortable with. I use Medtronic or Bonds, both the drills can be used. And here you can see the serial dilator is used as it was shown in the surgery in the first picture to create the space. The half sleeve or semi-lunar sheath can be used in the beginning to maintain the water column. If you in the beginning miss to maintain a water flow, then there is a risk of water going inside the facial plane. Then your surgery becomes very difficult. So I prefer using this sheet in the initial part of my surgery. But after some time, the tract gets patent, the water itself flow out, then you can remove the sheet if it's causing hindrance. Then there are different type of sheets for the microscope, and this is one instrument you should know. This is the root retractor. We use it when you do annuloplasty. We can retract the traversing root at the shoulder with this instrument, and we can do discectomy also. So there are different types of RF ablators also, and the chisels which can be used. We discussed that some people like to do under the cave work with the use of chisel. It's fast and easy, and trust me, if you keep your ligamentum flavum intact, over that chiseling is very safe. It seldom damage the nerve roots. Then the scope already has been discussed. Irrigation system, why we use irrigation system, and that's the thing which differentiate UBE or water-based system from the microscopic or tubular system, because it gives you an excellent view. All the debris which we are creating by drilling or the blood bleeding, it's get controlled and wash off. Even yesterday we were discussing with Dr. Gaurav sir, and his view is also that the root which is inflamed, it has a lot of inflammatory markers around it which get dewashed with that continuous saline flow. So patient have immediate improvement in the post-op symptoms because of this method. So, but we have to be very particular with the pressure. Do not increase the pressure too much. Keep it at the surgeon's height. Otherwise, patient will have neck pain or headache in the post-op period. So, where we can do the surgery: lumbar disc herniation, canal stenosis, lateral recess stenosis, facial cyst, foramen stenosis, OIL or bilateral decompression through unilateral side. So this is standard operating setup we have already seen in the OR, so I will not go for this. Patient positioning can be done on prone with the Wilson frame or chest boulder. Abdomen should be kept free. So now I'll start with level marking. So you mark a midline and see that incision is taken almost just paramedian to the midline. It's even less than 1 centimeter to the midline. This gives us benefit that from this line, the ipsilateral side and the contralateral side is almost at the equal distance. So imagine you are doing from the left side, and if you are taking your entry point to lateral or at the pedicle entry point, working on the ipsilateral side will always be a little difficult for you. You have to do more and more drilling to see the ipsilateral side. I trust that contralateral is very easy to see when you take a far lateral entry. But if you take a midline entry, you're working a space for both the sides is almost at the equal distance. So then we triangulate at the namaste point. I triangulate completely on the lateral image, just take an AP image to mark my midline, left midline. So we put two ports. Less than 1 centimeter incision is used, especially the camera port is very small, 4 to 5 mm. The working port is almost 1 centimeter. And you can keep it around 2 to 3 centimeter distance, depending upon the patient's BMI or patient's thickness where you have to reach. It's all simple physics. Dr. Gaurav has already discussed. So we'll just do the paraspinal muscle splitting. Under fluoroscopy guidance, we reach the spinolaminar junction, and from there we start working. So if we are doing fusion, then we have to take incisions lateral, that is over the pedicles, if we are planning for the fusion surgery. So that's how we triangulate, we place our port, and then that's how we drill. So these X-ray images we take in between to make us orient from where we are doing. So I'll just go with the small videos. Already the excellent demonstration has been done. So the steps are like this. We do first soft tissue removal using the ablator, and then after that we go to the lamina preparation for drilling. We completely denude the lamina of the soft tissue. And one point is there, this spinolaminar junction has to be kept in mind. And this is lateral, this is cranial, medial. So medially you have spinolaminar junction, that also we clear off. Because we need to drill this part of the spinous process to go contralateral over the roof. So we drill that. So drilling can be done in two methods. Some people use cutting bit for the cortical bone, and that part we can do very fast. That's called tactile drilling. We can feel the bone and we can drill fast. We need not worry about it. But once the cancellous bone is there, we can use the diamond drill and do a slow and mindful drilling by taking care, not injuring the drilling. Then we cut the lamina. We undercut the lamina till we reach the superior attachment of the flavum on the superior lamina. We keep on cutting it. I will just rush through the videos because we have already seen everything in the clinical demonstration, surgical demonstration. So phlebotomy is also, I do phlebotomy in piecemeal manner. It's the personal choice how you want to do phlebotomy. Some people prefer it by doing butterfly. Some people are using it in piecemeal as you wish. Lateral recess decompression is very much important, and there we use curved Garrison. And here I am using all the normal open surgical instruments. So this way we can decompress the lateral recess very well. Because if you don't free the lateral recess, if you don't decompress it, you have to do more and more retraction over the nerve root. So if you want good decompression with minimal retraction, you have to work on the lateral recess, especially on the symptomatic side and preferably on the bilateral. So This lateral recess decompression is being done. One more thing I want you to notice, see the inflamed root here, how much inflamed it is, because since years it's in compression and that's inflammatory markers are causing the patients to have symptoms. So we decompress the lateral recess and we do foraminectomy. Here you can see we'll do good foraminectomy. Can you imagine doing this foraminectomy and viewing it in such a view in any other air medium surgical method other than this, either monoportal or biportal? You can see like this. So annuloplasty, since the time I have started using UBE, my disc removal has been reduced significantly. Unless the annulus is already cleared, I will never ever put an instrument inside the annulus because it's itself increase the chances of degeneration then further. So we do annuloplasty. We just you can put a protective sheet and then do annuloplasty, or you can use the probe of cautery or ablator and then do it. So I will present some of my cases. You see this case, severe canal stenosis. We have done UBE, and you can see, imagine the space thecal sac is getting this post decompression. This is second case where the patient was having left side symptoms, large disc. Although in this image it feels like some of the disc is there, but good decompression is there. So the patient's symptoms is reduced because of that. Entire flavum has been removed. This is our third case. Unfortunately I don't have pre-op for this. This is fourth case. This I want to emphasize. This was a calcified disc, and also there was a sacralization of L5 at this level. So if you can appreciate in the CT also, the calcification can be seen here. So we did removal of calcified disc here. I use chisel for removing the calcified disc. You can also use the drill to remove the calcified disc here. Let's rush through the video. So this is final picture after decompression. You can see from the inferior lamina to the superior lamina, entire flavum has been removed. You can see the traversing root. In the upper window, you can see the exiting root, and the calcified disc has been removed. So another theory is there for calcified disc. You can also remove always drill the bump and then leave it like that. That also can be. So this is post-op for this patient. So much space has been created. This is case 5. This I did last week only. Patient had 2-level compression. So initially I was planning 3 incisions for doing this 2-level, but fortunately I could manage to do this with the same 2 incisions only. Here I want to emphasize in this surgical video. If you see, this is the exiting root at the upper level, L4, exiting root. This is the disc which annuloplasty has been done. And as you go down, this is your traversing root of L5. So this one level has been done, and then through the jumping from the same port, we have come to the next level. For the next level, this is again L5 is the exiting root. This is the disc we have decompressed and the traversing root. Part of my videos is not of very good qualities. So important thing I want to show you here after decompression, that I use this very same 2-port only for doing the 2-level decompression. So it was possible because there was a lordotic angle, but if the disc is at upper level, I prefer taking one more incision. So this is the amount of flavum we removed. Try to pick out the butterfly completely, but it was impossible. But the amount of flavum you see. So that the good decompression was achieved later on. This is young male, 22-year, presented with left side symptoms. Foraminal disc was there. I want to emphasize here, if you can see, this Baltic probe going inside the foramen. This is the amount of decompression we can achieve with the UV. You can see it here with your own eyes. This is post-op video. The complete decompression from the superior lamina to the inferior lamina has been done, and this annuloplasty has been done. This is the traversal route. Foraminectomy also has been done. So I'll rush through, I will not take them more time. So advantage, you see this image, you see the amount of bone it is. The entire spinous process is intact, muscle attachment is intact, and now every one of us knows that posterior ligament complex is the most important to maintain the spinal instability, and we are not at all touching that posterior ligament complex. The facet is not at all injured. We feel that so much of lateral decompression, lateral recess is being drilled, the patient will have instability in post-op. The amount of drilling you can see here. So the incision itself speaks a lot. A very cosmetic incision, 1 year follow-up, patient will not even remember the surgery was done. We make our patient mobilize the very next day. We preserve the muscle, no blood loss, short hospital stay. These are all secondary. You see the cosmetic incision of different cases. Thank you.
Very nice. I have a question. For 2 levels, is it 0-degree scope or you add on for 30 degree also?
I do my entire surgery with 0-degree scope, 3-degree scope.
Okay.
It's about comfort. I am comfortable with 0-degree. And the good thing is, it's a 4 mm scope. So even if it's 0-degree, you can slide it under the spinous process and you can go till the opposite side, and even you can see opposite side exiting route till the traversing route, the entire cavity through that scope. That's the beauty of UBE. I will say interlaminar monoportal is also a very good surgery. Even I accept it here. I was trained in monoportal. I did my fellowship from Korea in monoportal. But I started doing UBE and I'm loving it now. And I never think about going back to monoportal now, because the kind of vision, kind of freedom, the kind of decompression you achieve, and that too with the less instruments and less cost involved. Thank you.
Thank you, dear. Any question from audience?
Thank you, Dr. Arvind. I'll request Dr. Kartikeya Sharma to please come and give token of respect to. The next chairperson, I'll call Dr. Kartikeya Sharma from Prayagraj and Dr. Ashish Tiwari, if he is there. Yeah, please come. So the next talk is similar. So we have taken lumbar canal stenosis management from fusion to decompression only. Dr. Amrin is from Hyderabad. Dr. Min, please come. I'll request the presenters to stick to the time because maybe after this we can start the next operative. Dr. Amrit,
Yes.
please stick to the time.
Very good morning to the respected chairpersons and all the senior faculty and all the delegates. I am Dr. Amarendra, working in the Nizam Institute of Medical Sciences, Hyderabad. So today I want to share my experience with lumbar canal stenosis management, how especially over the last 15 to 20 years it is slowly changing, the concept of managing these cases is changing. So this is a typical MRI of a 65-year-old male patient, came with myogenic claudication, having bilateral rolling paresthesias and all. You can see there is a central canal stenosis compressing. It's almost like the Shia's grade C or D, where you can't even see any rootlets inside the thecal sac, and the thecal sac almost become like a tripod. So 15-20 years, these type of patients were managed with open laminectomy, which was a good procedure, having a good results, but there is a more collateral damage in the open procedure, where we are removing the almost undercutting the facet joints to free the roots. So that is causing almost up to 20% of the instability in post-operative cases for these cases. So people proposed fusion for these cases. When we started doing like last 10 years, we started T-lifts for these type of cases, where you put a large cage and fuse the segments and so as to increase the foraminal size also. So minimally invasive surgery over the last 2 decades is taken over the open surgery. So we have performed many minimally invasive T-lift surgeries. You can see we are using a tubular retractors and putting up percutaneous screws and the cages. When this lumbar canal stenosis is more than 2 levels, then we went on to do some cases oblique lumbar interbody fusion, where we are going through the retroperitoneal route anterior to the psoas muscle, and basically doing the same work, but we are not touching any of the neural elements. So the concept in OLIF is it will remodel the spinal canal once you put a large cage. The advantage of OLIF is compared to TLIF, you can put a large cages, almost up to 25, 26 very big broad cages. So that will remodel the spinal canal. So this was Allen table OT setup where we are planning the OLIFs. So there was some cumbersome part where we have to do with the microscope in OLIF. Then we started using these are the light sources from Globus actually, where we can with the naked eye also we can do without any use of a microscope. So we are mainly operated 2 or 3 levels that we are giving the good results. But the problems with these fusion things, they are very effective, but there are problems like there might be a screw breakage, or there might be a adjacent segment degeneration, which is a related complication. So people with the advent of endoscopes, again they are preferring endoscopic decompression rather than just only fusing and leading to these kind of complications. So here we found some this paper by Dr. Park, who is a pioneer in biportal endoscopy, where they have compared open versus minimally invasive TLIF versus endoscopic decompression. Almost 30 cases in each group, and maybe that over 1 year of follow-up period, most of the patients with unilateral biportal endoscopy and bilateral decompression patients are doing as good as with the minimally invasive as well as the open laminectomies. And moreover, the advantages of endoscopy anyway is there with the biportal endoscopy. See, this is another paper, same reiterating the same thing, that even for not only for a single level, by multiple levels of lumbar canal stenosis also can be managed with only endoscopic decompression. Some surgeons have done even with the grade 1 hysteresis also, they have tried only without fusion, they have done only endoscopic decompression, that is also finally giving a good results. So the trend is now to perform the endoscopic decompression rather than a fusion surgeries. So our experience with, we got the endoscope almost like 8 months back in things. So then we operated more than 200 endoscopic cases overall. But in that, the endoscopic lumbar decompression was done in 10 patients. And this is the index case where we will see a 60-year-old female patient with a low back pain and right lower limb radiculopathy for the last 3 months. So this is the MRI axial section at L4, L5 level. You can see just grade C, that is the complete CSF intensity within the dural sac has been lost and there is no rootlets that have been identified. The same thing is seen, you can see with the ligamentum flavum hypertrophy at the posterior part impinging on the central canal. So this is the preoperative CT. The first image is at the superior hemiparetic level, and the second image is at the disc level, and third image is at the inferior hemiparetic level. At the superior hemiparetic level, you can see there is a slight protrusion of the SAP into the rural foramen. That is causing the root compression. So we have to address these things. So careful reading of the preoperative CT and MR is utmost important, and we have to identify the pain generator, actually which is the reason in this type of cases. So this is our technique where we are in the facial profession. I'm not going into the techniques deep to detail. That has been discussed by Dr. Aravind. And we use only AP for triangulation. We will take the working port at the lower pedicle. If you are operating at L4, L5, male border of L5 pedicle is the working port, and 3 centimeters we take the camera port. So this is the triangulation, and this is a small video to show the adequate decompression. Once you clear the muscles, then go with the diameter. We use a clear view, that is a metronic drill which we will use for the skull base endoscopy. That we use in these type of cases. We find it very convenient. So we are drilling the superior lamina. So we'll proceed with the Z technique, that is first ipsilateral upper lamina, then contralateral upper lamina, come to the ipsilateral lower lamina, then go to the contralateral lower lamina. So once you start drilling the upper lamina and identify the ligamentum flavum attachment, we usually remove the ligamentum flavum like a butterfly, but there will be a ligamentum flavum deficient in the midline, so we'll take it as a 2 halves. And we'll make sure we'll see almost all of the roots, like the ipsilateral traversing, contralateral traversing, and contralateral exiting. So it is very difficult to see when you take the lateral pedicle, medial pedicular line as a entry point. It is very difficult with the existing root at the same side. So then we are drilling it, and this is a sheath. You can see this is a sheath of instrument of camera sheath. With that we can retract that ligamentum flavum down and safely drill the above port. So we are going to the contralateral drill side, and then we are going to the contralateral lower basis where we are drilling the IAP. And slowly, this is another lateral recess we are taking out. Then we use a scoop to detach the ligament flavum attachment on all the sides. Again, you can see slowly we are removing the half of the ligament flavum. And then there is as you can see, then there is adhesions between the ligamentum flavum as well as the dura. So we use the sheath to pull up the ligamentum flavum and see those adhesions, rather than just pulling it up with the abstract. We are just trying to clearly delineate the plane between the ligamentum flavum as well as the dura. So this is the contralateral exiting route. Sometimes it's very difficult to see the exiting route. Then there was no disc bulge as such, so we didn't do any discectomy. So this is the lateral route. So this is the final decompression picture. You can see a nice neural sac pulsating with a lot of space. So this is the ligament flavum we remove. We remove, like I mentioned, 2 halves. One half on one side, another one. And these are the incisions. We usually put a small drain for 24 hours. So if you take the same post-op scan, this is the pre-op scan where I mentioned this is superior articular facet tip is impinging onto the foramina. You see the post-op thing that the tip has gone. Same thing at the disc level. You see this much of lamina with the preservation of the facet. We are removing the bone. Even if you, maybe 50% of the inferior articular process sometimes needs to be drilled for the adequate decompression, because you need to see the attachment of ligamentum flavum. But we are preserving the opposite side facet as well as the posterior ligamentous structures, so the chance of instability is as low as like 2 to 3% in biportal endoscopy. So this is another at the inferior level. showing the bone removal. And if you see the MRI, this is the pre-op MRI, as I mentioned, there is no CSF signal intensity. This is the 2 days after post-op, you can clearly see there is a large, the thickness has expanded and you can appreciate the rootlets which is inside. So it has become from grade D to almost grade A. The same thing on the sagittal, you can see the posterior part of the ligament of flexion is completely gone. We didn't touch the disc part. And this is another case where there is a male patient having the same type of stenosis, and after 2 days at the L4, L5 disc level, there is a very much bulge of the cecal sac and adequate decompression achieved. This is also seen at the level of the superior end plate. You can see nice rootlets have come. So total we have operated 10 cases, all of them are doing well. There is a very much significant improvement in the last score, and as well as for back and leg, and post-op longest follow-up is around 9 months, and the shortest is just what was showed in the last one. So to conclude, endoscopic decompression is a safe and effective method for the lumbar canal stenosis, and also producing a similar results like the fusion and removing its complications, and proper patient selection and anatomical orientation is very much important in achieving the optimal outcomes. Thank you.
Thank you, Doctor. Although it was a very small series, but presentation, and you have done a nice work. My one question that I'm an old timer, I'm not an endoscopic surgeon. Although learning and trying to do it in a simple cases. But the problem what I face in the open surgery, especially at the age of 65, 70, well-built man with the osteophytes, and the posterior osteophytes are calcified even in the open surgery. We sweat like anything in removing those osteophytes. So I don't know, but the persons who are doing this procedure, they may tell us how do you remove, because if you leave a small amount of the osteophyte in the central part, so be sure after 6 months that patient will be after you with the plane. And I have done many cases in the open surgery, I'm doing even the fixation, everything. But just want to ask, the GP is also here and he may be able to tell that what are the technique you are applying, because you are going under the cord, over the cord on the opposite side. But those osteophytes, in some cases we have to retract especially at the L4, 5 level, whole of the sac is retracted on one side and then we drill it. And even in that, few of the times we injure or we open the tumor and there is a good CSF leak. So these are the small complications which I have already faced in the past. I just want how the endoscopic surgeons are dealing, or how they do and how they confront these cases.
If the osteophytes are at the lower level, especially 3, 4, 4, 5, S1, as you said, like in open procedure, we can retract the thecal sac and then later with the help of a chisel we can do it. But it is when it is higher up, L2 and L3, usually we don't try to retract the part because invariably it can cause some deficits. In those cases, I think fusion will be the better option rather than only decompression. Yes.
Removing those osteophytes is very difficult.
Yes, but endoscopically also we can do it at the lower levels. Yeah.
Basically, I do not touch the osteophyte. I never touch the osteophyte. I remove all the compressing elements from behind, but never try to touch the osteophyte. Never chisel them, never drill them, never touch them, because it causes a lot of post-operative pain.
Basically, there is no need of removing. Basically, there is no need of removing the
Osteophyte.
No need of removing the osteophyte. If you are doing a nice dural decompression as well as the lateral recess, then let it be there. That is not causing any harm. So yes, if the posterior decompression is not good, your lateral recesses are not good, if your nerve root is buckling with the osteophytes, then the patient will have a symptom. Otherwise, if it's free, then there is no need to tackle the osteophytes. Yes, it's a significant bulging disc, or if it's a calcified disc, then obviously you have to remove it. You cannot leave as such. If there is a calcified big disc, if you are leaving, your nerve root will never deplete.
One more thing. You showed the scan. In the post-op, there was this bulge still visible in the MRI.
Yes, sir. That is my
What was your experience? Yeah, I would have done in the same sitting instead of leaving it just like that. Even if the disc was not extruded, so I would have gone to the colonoscopy, gone to the endoscopy, even the RFI. So, what's your take on that?
This patient actually did very well after the decompression, but intraoperatively we felt that the disc was very mild bulge was there. There is no need of destroying the annulus and creating other complications. So we thought to do that.
But you are doing plastic.
Yes. If we feel there is a disc.
I'll just interrupt. We are ready with the second case. So we go directly to the OT and then we'll have the lectures. Thank you, Dr. Amrit. Just wait, we will have some presentation. Please come. Request audio visual to put on the OT. We'll have the second case. Nikhil. Nikhil is here.
बैठी कैमरा बुला दें पूरा अरे कोना खींचना.
So we are going to have the second case of UBE live session. The operating surgeon is Dr. Nikunj Yogi from Nepal. He is this patient is 40-year-old female, complains of low back pain for 7 years, with radicular pain in the left lower limb with mild tingling sensation for 5 years, and radicular pain in the right lower limb with mild tingling sensation for 3 months. No significant medical history. Surgical history, she underwent some C-section in 2019 and appendectomy in 2006. And examination neurologically, right leg SLR is restricted, that is 30 degree, and left leg is 70 degree. This is the consent we are taking for this surgery demonstration. Blood investigations are in the normal limit. This dynamic X-ray shows no listhesis. We come to the MRI sagittal. You can see the L5S1 disc which is going up. You can see there is a upward migration. You can see the axial cut also. L5S1, this is more towards right side.
Evergreen boss.
So he'll be operating from the left side, and now we go to the OT, and then we talk to the surgeon. Thank you.
Hello. Good afternoon, sir. Am I audible? Yes, you are audible. So now we will speaking. मेरी आपकी आवाज बहुत कम आ रही है. You are not able to hear anything. Please turn up the volume. Very, very less.
Hello.
Hello.
Are you audible?
Yeah, now it's audible.
Are you audible now?
Pushed a bit higher.
Hello.
Hello?
Not better. It's good. Yeah, it's good now. It's good. Hello. Yeah, it's good.
आवाज आ रही है तुम्हारी? आ रही है.
Sir. So, sir, I introduce the coordinator for this case, Dr. Rohit Vadikar, sir, from Medical Hospital, Senior Consultant Neurosurgeon, Hyderabad. He is a student of Dr. Park himself for UBE. He is one of the pioneers for my batch and my generation in UBE surgery. So, I'll just hand over the case to him. Thank you.
Hello. Good afternoon, everyone. I'm Dr. Rohit. I'll be moderating this session. So, like Oja sir has already explained, there's a little change in plan. This is the FY1 up-migrated disc. And the slight change in plan is that the surgeon will be standing on the right side and not on the left side. This is not very conventional because for a right-handed surgeon to stand on right side and operating, the working port comes cranially in your right hand and the endoscopic port comes on the left hand, which is caudally. So there is always a conflict when you are doing a bony drilling because you don't have the angle to drill it cranially. But that's what I explained and I spoke with sir, so he's an ambidextrous surgeon. So he'll be interchanging the ports, camera, and he'll be operating and drilling with both hands. So that is something new we all are going to watch now. Till the time OT is getting prepared, so I would just like to highlight few aspects regarding the right-sided surgery for a right-handed person. One conventional type is you are for a right-handed surgeon, you are standing on the right side of the patient and creating two ports. And the cranial one is the working port in this, and the caudal one is the scoping port. The other approach is over the top kind of, where you are standing on the left side of the patient, but you are making incisions on the right side of the patient across the spine or spinal process, and then you work the same way as you are working on the left side, and then the anatomy is a bit better, the orientation is a bit better. You can do that way as well. And third way is as shown in the previous operative video, where you are standing on the left side still, even for right side pathology, and you go across from under the spinal process and tackle the pathology on the right side from starting to the left side. So the average surgeon, UBE surgeon has a kind of a preference what they want to do, and they do surgery accordingly.
Thank you. I like to take Dr. Ashutosh's opinion. Dr. Ashutosh is here. He operated the first case very nicely. I think he did a good applause.
Thank you, sir. Thank you for the opportunity. And this is a upgraded disc, and in a upgraded disc, it is important to grade the severity. And the severity is based upon how much it is associated with the upper pedicle or the migrated disc. Because to address this problem, you have to increase your extent of laminectomy more trenary. So unless you have a prior idea what is the landmark, you cannot what you will do is that without that idea, first you will remove some lamina, go inside, then you will find that no, it's still not the base. Then again you will have to do the laminectomy. So that increases the risk for dural tear. So pre-operatively, how to plan is, you see what is its relationship with the pedicle. And then when you are making the port, then give cognizance that how you are viewing port, because it's up migrated if you are working from the left side. And you see with respect to your the port which is nearest, how much above it is. Like if you keep a port straight, how many millimeters above or below the disc upper edges. That gives an idea how much bony work you have to do, so that you don't have to take the CM again and again. This reduces your operative time, reduces the dural tear. So for up migrated or down migrated disc, it is better to plan it pre-operatively with respect to the pedicle, and then plan your ports accordingly. So that is one my the nuances associated with it.
Thank you.
I have a question for the up-migrated disc. Do you plan your triangulation directly on the C, or do you plan your triangulation with the level of the pedicle? Because normally what I plan, that I always try to plan my triangulation on the C, and then I bring it across. So do you change your plan with that?
One of the important concept of UBE is that you should not injure the multifidus. Now the multifidus has its origin from the mammillary process. So if you are talking over the facet, there is greater chance that you are going to injure the origin. And also this is the same area from where it receives its nerve supply, as well as you have the superior articular artery from there. So if you are talking in that area, you are actually, especially for the disc, then you are actually endangering the multifidus. If you are doing it for tail, that is a different thing, because anyway you have to remove the facet. But for up-migrated disc, if you talk at the facet, there is greater chance that you will injure the multifidus. Now, so where you should talk? The talking is not going to alter how much movement you are going to have with your viewing port or the working port, because that is independent. That is the main benefit of UBE. So it doesn't matter where it is migrated. Yes, sometimes if it's migrated even up to the lower disc level, then you can modify your approach. Like you can do initial discectomy at the level of herniation, and then you change the working port. I'm talking about working from the left side. You change the working, first you do from the lower part, and then you change your viewing port to the working port and make a new working, new viewing port. Second port. That is better, because your main aim is not just reducing the incision. Your main aim is that the muscles should not be affected. That is what is minimally invasive. So as such, my take is you don't change your port position just because the kind of discectomy it is there. And plus, if you practice the same thing again and again, you will be more successful. Because the most important thing in UBE is making the port. If you are making the port properly, everything else is easy.
Any other? So Rohit,
Yes, sir.
can you give some commentary what is going on inside the OT?
We are just now painted and draped.
Okay.
And then we'll let you know the.
Basically,
Then
you
we
are
are going to the placement of the ports.
surgeon standing on the left side,
Surgeon is standing on the right side, sir.
right side, sir.
Right side,
Right side. Okay.
Dr. Nikolchik, in the time we start, can you tell the audience what would be the markings like, what you plan to do, and how will you do it?
Yeah. Once the drilling is done, sir, we'll let you know how we are going to plan the incidents at the market. Yeah. He's going to do it very classical way, and we'll be coming back to you with the positioning. So we have, as you can see here, because it's alpha S1 and it's slightly upmigrated disc. Push to it. Take instrument there. So this is the alpha S1 upmigrated disc here. And the disc space is very narrow here, so we have broken the table and tried to open, because if you see the interlaminar space here is very narrow. So we have broken the table and we have tried to open the interlaminar space, so it will be easy for us while drilling the bone. And we have already squared the vertebra on the C-arm. So here you can see, we already squared in an AP view. The spinal process is midline, is in center and is equidistant from both the pedicles, alpha pedicles. Like sir said, right-sided pathology can be dealt from either the surgeon standing on right side, which is a bit unconventional for a right-handed surgeon. Me personally, I stand on left side, and like someone was mentioning, I stand on left side and then give incision across the midline. That way you can maintain your dexterity, and also you can do it the similar way how you do it on the left side.
So which one you prefer, Dr. Rohit?
Me personally, I prefer standing on left side, sir, because I am not that ambidextrous person. Because in standing on right side, you will always conflict with the lamina, because your working focal will be cranially. So this is something new I also will be watching today.
Dr. Rohit, meanwhile, can you tell about how to be draped in UBE to the audience?
Yeah. So the patient is a young female. We have positioned the patient in prone position on Wilson frame, and like I said, because it's an XI disc and a narrow space, interlaminar space, we have broken the table. And we generally use for draping, we use a craniotomy surgery craniotomy drape, which itself is very good. It has a connecting pouch here from where the water can get collected and you can easily suck it out or drain it outside. And now you can show there. So
So now we'll be planning our entry point. So first of all, we'll be taking the shoot at the disc level. So the planning will be first will be marking the midline, and then we'll mark the disc level after squaring the vertebra, and then we'll mark the middle pedicular line between L5 pedicle, right L5 pedicle and right S1 pedicle, and the entry point will be at the inferior border of both the pedicles at the medial pedicular line, and through that we'll be doing triangulation on the spinal laminal junction. And then you start
ask the cameraman to focus on the draping. At least people will see the draping. We took lights back.
Draping is how the instruments are placed around the jugular.
We'll just square the vertebra again and we'll. This is the thing that happens if we keep on moving the C-arm and we do not lock it.
We're not able to see anything through this, just the OT lights are visible.
Hello, Neeraj? Rohit? Dr. Rohit or Neeraj from OT? Anybody can respond? We welcome Dr. Mahesh Sharma from Diwani.
हाँ जबरदस्त प्रेजेंटेशन है, झाड़ है ये।
As OT is getting ready, there are some issues on the table, so we'll have one presentation. Call for the next lecture, we'll call the chairperson. We'll call Dr. Mahesh Sharma and Dr. Jaideep Chandra to chair the session. We'll request chairperson to please take the seat. And I request the next presenter, Dr. Avnish Rai, who is a senior neurosurgeon from Varanasi Care Hospital, to present the microscopic discectomy to UBE transition journey.
Thank you, Honorable President and leaders for giving me this opportunity to present my early work. I am a very early UBE surgeon and I have been in this practice for only 1 year. But I want to share my story because I was never trained formally to do UBE. I just attended one workshop and from there I started seeing the videos and following it. And my initial cases were, I had to plan it that whether I have to convert my cases to microscopic because I did not want to give any problem to my patients. So I'll share some of the slides and then I'll share my journey, what problem I had with different instruments, drills and all those things. So this is a case, I had few cases of microscopic surgery and this was one of the case that I operated a 40-year-old male patient and he was treated for radiculopathy and I did microscopic surgery. The patient was free of his radicular symptom but he said that I am having more back pain after the surgery. Then I started following the endoscopic surgeries principle. I used to do transforaminal surgery in 2016-17 but I was very unhappy with that. I went to Dr. Gore and I learned it, but my initial 2 or 3 cases were not good. So I was not very hopeful of shifting it to endoscopic surgery. Why I made this transition was there is a increasing demand for the minimally invasive surgery, and the patient now come to us who say that I want to go for that endoscopic surgery. Then there is a patient expectation, and they expect less pain, and they want a early discharge. And there has been a technological advancement in endoscopic, and also there is a competitive academic and clinical environment. UBE is my choice because the cost is low, and since we are treating lot of the patient from Ayushman also, and I told that I had a few cases of transforaminal, then I tried on monoportal also, but I found it one of the most familiar endoscopic choices because all my upcuts, drill, everything was same, and the cost of the patient treatment was also low. In microscopic spine surgery, we identify to have a 3D binocular vision, we have a direct tactile feedback, we have familiar midline anatomy, and we have a long established outcome course of that. What is the limitation of pure microscopic surgery? We have lot of muscle retraction injuries. The contralateral size is not very clearly visualized, and we have to open whole of the lamina. There is some amount of approach related morbidity because of the muscle retraction, and it has a longer recovery time compared to the endoscopic technique. As everyone has said, and we have already seen in the videos also, it's a dual portrait technique. There is a continuous saline irrigation, and there is a magnified view, and there is a dynamic instrument maneuverability in this. What is the mindset required? Mindset is, this is the beginning that makes you a shift to a new technique. Microscope, we have been trained in microscope as a neurosurgeon, and we are very well accustomed to the microscope. But we have to shift from 3D eyes to 2D monitor. And once we start using a microscope, endoscope, we have a very easy journey of either we go for transsphenoidal surgery or we go for ETB or any endoscopic procedure. From static corridor to the dynamic field, from the dry field to the fluid medium, and we have enhanced spatial orientation skills. The technical difference is basically microscopic is a single incision, muscle retraction, and there is a fixed working angle. We can move the microscope and see from the different angle, but there is generally a limitation. While in UBE, we have small two portals, minimal muscle trauma, and we can have a wide angle of triangulation. Anatomical orientation is somewhat similar in both identify lamina and flavum, systemic compression, clear visualization of the traversing exiting nerve root, and contralateral recess SS. Skill adaptation is the primary thing where we have to have a hand-eye coordination, and sometimes we have to learn on the monitors or dry field also whether we are moving the endoscope and seeing the instrument, because initial part there is a lot of struggle. When you are trying to see from the endoscope, your instrument set will not be visible and you will be fighting with that. So the hand-eye coordination is the initial thing. Bleeding control in a fluid medium is also somewhat difficult. And I had a struggle because when I was using I was doing at a low water pressure medium, and I had that bleeding, all the bleeding coming. Then I tried to increase the water pressure and the better use of the cautery. Sometimes there was bleeding from the bone, and you were trying to apply the bone wax and you are not able to apply the bone wax. You are frustrated that my bone wax is falling down. Then you start using the drill in a reverse gear technique, then you start putting the bone wax on the drill edge. So these are the various techniques which you learn over the time, and there is a depth perception adjustment in endoscope, and initial triangulation mastery is very difficult. My journey was, I started from the triangulation from picking the inferior pedicle point. Then I shifted to midline portal because I found that midline biportal was very easy and I did not require the help of any X-ray man, and it was very, very fast. So initially I was doing on planning through that pedicle part, but now I am doing more from midline side because I found it more easy for the beginners to learn. That is my story. Learning curve, initial first 10 to 15 Ks is a orientation phase, and I had to orient myself for at least initial 5 to 7 cases, and I was really confused how to change this to microscope. Then I found a technique. I tried to put a longitudinal incision, and initial few cases when I was not very happy with my endoscope view and all those things, then I shifted it to microscope. So you should always be ready to shift to a microscopic technique. Whenever you feel that you are not adequately trained or you don't have a senior to help somewhere. Now, after 15 to 30 cases, the things have improved, and I find it more easy to handle my drill and all those things. Regarding the instruments also, the drill part has been really frustrating, because what happens whenever you do your surgeries under the water medium, the water has a tendency to go inside the drill. So you are always frustrated with the drill, which company drill I have to buy. And I found, at least I have tried on 3 drills, and all the 3 drills have been very frustrating for me. And there have been frequent repair and all those things. So these things will gradually improve over the time. Once you cross that threshold of 30 cases, you have confidence and you are at the advanced level, and then you can plan your fusion cases and all those cases. And I feel that you should have some mentor and basic category training skill to enhance your skill. The challenges we faced was incision related. I've already told you that I tried to shift to midline. Then there is a fight with water inflow and outflow related, because initial part, when you dissect through the muscles, you are not able to create that water tunnel. And what happens, that water keeps storing inside that cavity, and you find that your back has swollen, the patient back has swollen up. And then you try to insert some instrument so that your water flow is started. So this water flow is very important, and now I feel when you operate under a high water flow, your muscles retraction problem is also solved, and you can also insert your different instrument from the port side. Instrument related drill I have already told, and the problems I faced in the triangulation part, that has somewhat improved with midline by portal technique, where I don't need the help of need the help of CM. Complication awareness is dural tear. I was always thinking, if I have a dural tear, how I'm going to recognize that dural tear, because that is under the water flow and you cannot appreciate that CSF leak. I'm still confused whether it is very difficult to see unless and until you see the root coming out from the dura. You will not be able to appreciate that dural tear, because you are already working under the high pressure. And I think this is the advantage of the UBE also, because since you are creating a pressure, the chances of dural tear I think is less, because the cord is already pushed against the water flow. Inadequate decompression is very common. I had a patient when I operated, and I thought that I had taken out the disc, and the next day the patient was saying that I am having more severe pain, radicular pain. I had to change that patient to next day to microscopic surgery. There is risk of a thermal injury, because when you are using a RF ablation, you sometimes in the initial cases, when you see the bleeding, you have the tendency to burn it, and sometimes you can cause some amount of thermal injury to the nerve root. Then there is a fluid related issue, because you are not confident with the inflow and the outflow of the fluid. There is a tendency of water to get collected inside the back space, and that is going to create problem for the patients. So these are the basic strategies that you attend the hands-on workshop, observe experienced surgeon, and start with a simple disc or a flavum hypertrophy at L4, L5 level, and maintain a low threshold for the conversion. Clinical outcome is they have a very good pain score. We have very reduced post-operative back pain, very shorter stay, and the faster return to the work. And I think this is going to expand your surgical skills, academic opportunities, and increase patient satisfaction, and you are ready to move to the next goal. So my take-home message is microsurgical principles remain the foundation. UBE adds minimally invasive advantage. Transition is both technical plus as psychological. and structured training is going to help you. And this is the incision of midline, and normally in initial cases I was using this brain abscess needle. Now I use it. I found it very handy. And sometimes when I feel that I have not taken out the adequate disc, I always insert this brain abscess needle, brain needle being and neurosurgeon. And when I take out that water port, I instill the steroid in this. So sometimes you have that better outcome, and you have given that steroid, and if you have not taken out the disc also completely and you're not sure, you can have that better patient outcome in those cases also. Thank you.
Thank you, Amrish. Good presentation. Just hold on for the. Please come here for the. I request chairperson to please come and give a token of respect to Dr. Amrish. I'll request our young assistant professor, please come, Dr. Sunil, to give the token of respect to our guests. Please shift to the vote as patient is getting Neeraj, Dr. Rohit, sir, we are watching you.
Am I audible?
Yeah.
So I'll take you to the part which was missed by the audience during the presentation. So the marking part was sir has done. I showed you on CM images. So initially he has marked the disc level alpha S1 in an AP position. Then he has marked the midline. Later he has marked medial pedicular line. And then he is planning to mark the inferior border of the right S1 pedicle. So this is inferior border of right S1 pedicle. This was marked. Then inferior border of right L5 pedicle was marked.
Difficult. So
Yeah, so here you can see the inferior margin of the right L5 pedicle. So three lines are marked on the patient: the midline, medial pedicular line, inferior border of right L5 pedicle, and inferior border of right S1 pedicle. So through the inferior border of pedicles, sir has inserted two needles quite more needles. And he's trying to angulate the inferior needle towards the, if you can see the needle which has been passed through the inferior border of right S1 pedicle, he is trying to angulate to the SL spinal laminar junction of the L5 vertebra. And now the incisions have been placed at the needle positions. The incisions were taken as horizontal incisions. Generally, horizontal incisions cut the fascia very properly, and water outflow will be good rather than. So, if you are a new learner, when you feel that sometimes you might have to convert the surgery into open surgery, it's always better to take vertical incisions. But then in vertical incisions, the fascia is also cut vertical and the outflow is not that good, which you will find when you take the fascia cuts in horizontal. So if you are experienced enough and confident enough, it's preferable to take the horizontal incision so that your outflow is good. So sir has taken two horizontal incisions at inferior pedicular line. And as you can see, now he's already inside. So right hand he is holding the camera and left hand he is using RF. So he is trying to remove the lamina. The soft tissue is being removed from the lamina, and whatever small needles are there, he is trying to control them with a 90-degree RF probe, plasma probe. Here you can see the inferior margin of the L5 lamina. The big L5 lamina, inferior margin. You can make out that he's standing on right side of the patient and the camera port is on right hand and the working port is on left hand. This is the advantage of being an ambidextrous surgeon. So now his RF pointer is at most probably it's spinal laminar junction of alpha vertebra. The movements have to be very precise here because your RF probe is working near your camera lens also, so you don't want to damage either with the RF or with your drill. So your hand movements have to be very precise. We want to confirm the position again, so we are going to take one AP shoot just to confirm that we are at correct position.
Yes. Lemon and lower border is reversed.
Yeah, so the probe, the RF probe is at spinal lamina junction. Yeah, and the camera is slightly lower down on the lower lamina, that's one lamina. So we have confirmed the position, now we are good to go ahead. Sir wants to confirm one that also just confirm one thing.
It's very important that you will confirm the level. And is it see that sometimes you migrate up and down or beat the Siam and extend by check, recheck. But once you started the bone work, then everything is repeated. In both UAP and lateral is before confirming don't start bone work. Start bone work after the confirmation of label. The interluminary space at alpha S1 is wide. Don't need more bone work if it is not migrated upward. Migrated upward, then you need some bone work up to the pedal, lower bottom.
We have slightly missed the position. Now we are at S2, so we will have to rework it up to alpha S1. So it's very important you confirm your position by doing AP lateral. If you have any doubt, this being alpha S1, the curvature of the sacrum also changes. So you have to be doubly sure. Higher up, L4, 5, L3, 4, it's a bit simple. But your angulation changes, the way the surgeon is standing and how the patient is and how the spine is curving. You have to change your angulation accordingly. So we'll try to do slightly up. Now we are at alpha S1. Slight cranial angulation and we were at alpha S1 and slightest caudal angulation, we were at S2. We have to be very careful while putting your instruments and angulating. good general cutting of the fascia. Generally, in upper interlaminar spaces like LC4, L4, 5, when you are trying to triangulate and you are trying to feel the lamina, you feel a step. When you feel a step, then you are sure that you are at the inferior border or you are at the spinal laminar junction. But here, because the L5 S1 is very crowded, so you are not feeling that step and you are immediately going on to the S1. So probably that is the reason you missed it. Probably that is the reason we should be breaking the table and opening the interlaminar spaces, especially in L5 so that the interlaminar window widens, and while moving and feeling the spinal laminar junction, we can feel the step. थोड़ा नीचे लगे Sir is standing on right side and the linear what you are seeing will be a working channel. It is in line with the disk space for you to be in line with the parallel with the disk space. So L5 inferior border, L5 laminar inferior border being denuded. And because endoscopic port is caudally, what you are seeing is the undersurface of L5. So I just orient everyone. So I'll orient you. 12 o'clock is median. Yeah. So can you just keep it neutral for a second so that I can just orient this one? Yeah. So medially, so 12 o'clock is median, 3 o'clock is spinal laminar junction, L5 lamina inferior border. 6 o'clock is lateral towards the facet, and 9 o'clock will be border.
we are going immediately towards the spinal lamina junction now. इधर आ जाओ। Right leg.
Hello. I think we'll have a lecture because they will have to go a little bit up, as Neeraj is saying. So we'll have our chairpersons. I'll call Dr. Gaurav Srivastava. Dr. Nitish, please come. The speaker is Dr. O.P. Singh. He'll be speaking on UBE ossified yellow ligament of thoracic spine. Dr. O.P. Singh is from Prayagraj, a senior neurosurgeon, and earlier he was doing his stand-up, now shifted to UBE. Dr. O.P. Singh, please come.
ले लिए तो क्या बोला था
Good afternoon, everybody. I am Dr. O.P. Singh from Prayagraj, and I am presenting about the UBE thoracic spine. Thoracic spine UBE is a demanding procedure, but not as much as in cervical spine. And there are some anatomical differences from lumbar spine that have to be kept in mind. And one thing is the interlaminar window is very small in thoracic spine. Bone is very much covering of the spine guard. So you have easy stripping of the soft tissues. So that is one advantage. You can boldly do stripping of the soft tissues. And spinal process is not facet is horizontally oriented. You can see in this figure. This is the lumbar spine. This is the C-shaped facet, SAP, where this is SAP, and covering most of the part of spinal canal. You can see this is the interluminal area. This is the lamina. Pars is not very much prominent. I think lumbar spine pars is clear over the foramen. And this is the bulbous part of IAP spinal process. This is lumbar spine, this is thoracic spine. You can see the difference. This is slender, this is fatty. And you can see this for articulation. This is the IAP, SAP, this is facet joint. And this is very small interluminal area that you have to approach. You have to triangulate here. And this is spinal process. After disarticulation, you can see this is SAP, this is the interluminal area, and upper body spinal process. So you can see this area is covered by the spinal process. Very minimal area where you can land on the bone. You can see this diagram. This is spinal process. The base is very wide, and this is IUP, UCP, and for the joint. This is our area where we work, start our work. Then there are this is thoracic guard, spinal guard. You have to be aware of where to work more, where to you should not go there. And in this case, this is a safe zone, upper bilateral, lateral medial and this. Thoracic portals, usually because the central facet, lamina and muscle ligament structures, were discussed indications, thoracic spinal stenosis, ossified ligamentum flavum, annual cyst, acute disc prolapse, sometimes osteoporotic fracture may be the indication for UBE in thoracic spine. And coming to the confirmation of the level, confirm and count the level from the ER, and start from C1 or you can start from the L5, and by walking technique of needle as you do open surgery. So we draw 3 lines. One is midline, this is midline. Midline, lateral pedicular line, and from this we angulate on the spinal lamina junction. The markings are similar to cervical spine. One thing is after the triangulation, we have to introduce the serial dilators repeatedly over the bone. You land on the bone. On the bone, it is safe to don't migrate laterally or medially. So after placing on the dilators from the working portal, you prepare working portal first, and after you place all the dilators, keep it there and just angulate over this dilated part. Dilated part is very easy for triangulate. So once you have put all the dilators, and then you put the scope portal, because the scope portal is smaller. It is 5-6 millimeters. 4 millimeters is the scope, and the is equal to 6 millimeters. So just you start after the triangulation. Then coming to the different types of ossified elbow ligament. As you know, the ossification starts from the facet joint and it spreads over the midline. So according to this, we divide, it was divided by Dr. Sato about how 5 types of ossification of ligament. So type 1 is limited to the joint. You can see in the diagram. This is the starting of the ossification. Then is banded type, then enlarged type, enlargement, then it fused in the midline, fused type, and then tuberous type. So this one is more dangerous than these 3. And the symptoms according to the area of involvement of spinal cord, if it is a posterior cord involvement, then there is only proprioceptive disorders. Then lateral spinal tract, and depending on the severity of the compression. Then this is the case I am presenting a 36-year-old female with tingling and numbness for last 1 year, and then she had weakness of rolling for last 2 months. She was unable to walk for last 15 days. And the power in both limbs was on the hip 3/5 and 2/5 on the left side. So left was more affected. This is the ankle MRI corner. It is a sagittal MRI, and there is compression at the D10 level. This is axial. This is CT scan on this stem. to give triangulation. After putting the all dilator, just land on the dilator. This is video of the frame case. The one more important thing is about the setting of drill. Once you get your drill reverse setting, so it is far from the cart. It will not danger the cart. So always use the drill in reverse cutting, not forward cutting. Because once it skids, it will hit the cart and cause the damage. It is very safe for any neural structures you are working around. Your drill should be in reverse cutting mode and diamond well. This is the I am drilling along the SAP and the through lamina. Because here there is no ligament of level. We create the entry point, and this is the safer zone, and this is ossified ligament at 11 o'clock, and this is midline, and upper attachment of the ligamentum. This is the lower attachment of ligamentum 7. I am cutting the lower lamina, and after marking all around the ligamentum 7, I try to work in safer zone. After once you degrade the ligamentum from all around, just dissect it out away from the card with dissector and take it out. Fully decompressed thickle size card. The question could be used 2 mm or 1 mm, and the working of instrument will be always in vision. First you see the instrument, then place over the for action. And this drill having a guard for opposite underlateral working for drilling of the hanging part of the SAP. So you should be having a dural protectant, so dural protected. This is a post-operative MRI, the same patient. The whole mass of ossified ligament of them is removed. And the gel cut. There was card changes before the operation, so this patient took time, but now it is much better. So, in conclusion, we can say that UBE surgery for holding ossified ligament of the is safe and effective in selected cases. The most important thing is hydrodissection by the saline, which clears the brain and it is safe removal of ossified ligament. It can shift card up to 1 to 2 millimeter away from the ligament schema, and you can easily put your 1 mm or 2 mm variation under the and bloodless state. There is no chance of if it is now flow of your saline is okay, there is no chance of injury. Thank you so much.
Thank you, Dr. OP Singh. We'll, because OT is ready, so just have some presentation. We'll call chairperson, please come and give our token of respect to Dr. OP Singh, please.
Audible, sir?
Thank you. We'll go to OT, and after that, we'll see. First, we'll go to the OT. Okay. Hello, Neeraj? Hello?
Yes, sir. Are we audible, sir?
Yeah. Rohit.
So I just reorient, sir. We are again back.
Yeah.
So what you're seeing is the inter margin of the alpha lamina has been built.
Okay.
And the point where there is light opening in the phlegm, that is the midline.
Okay. So, please orient us.
And now we will be taking out the lamina. The
Medial, lateral, superior,
The
inferior.
interlaminar space is very narrow here, so that's the reason it was very narrow, sir. We'll show it now.
First, Rohit, just orient about superior, inferior, medial.
I'll just reorient, sir.
Yeah.
12 o'clock is medial, 3 o'clock is cranial, 6 o'clock is lateral towards facet, and 9 o'clock is caudal. 6 o'clock is the facet, 12 o'clock is midline, 3 o'clock is the superior lamina. Yeah. And inferiorly we can also see the lower lamina. It's very close. This is the S1 lamina. That is the alpha lamina. Cranially alpha lamina at 3 o'clock. 9 o'clock is S1 lamina. 6 o'clock is lateral. 12 o'clock is medial. We are using a 30-degree scope, so that's why we are seeing the undersurface of the lamina. So, slight drilling of the spinophacetal junction.
Rohit, please ask them to make the endoscopic video bigger. That's the main screen.
Any questions from the audience? And now the orientation is slightly changed. Yes. Now what you are seeing in the center of the screen is the facet, and inferiorly is caudal, superiorly is cranial. O'clock is lateral, 9 o'clock is medial, 12 o'clock is cranial, 6 o'clock is inferior. This can only be done by using a 30-degree camera, so it's not possible with a 0 degree. Meanwhile, any questions are there from the audience we can take? Yeah, we have changed back the orientation again. Yes. You might be appreciating we have reoriented ourselves again. Now 3 o'clock is cranial. Yes. So at spinophacetal junction, we are cutting some bone just to delineate the lateral. We are detaching the phlegm laterally. can see the equitable space there. Equitable pad is slightly visible there. Separating the right side attachment of the flame to the lamina. Try to slightly peel off the flame down. Detaching the lateral attachment of the flame again so that we can again peel it off easily. So it's a sequential process. You just peel off from above downwards and detach the flame from lateral. So that easily separates and peel off. You don't have to take it out in a piecemeal manner.
Ready?
So we have again reconfirmed our position. Yes. What are those? Yes. So we have again reaffirmed our position in alpha S1 space. You can see the working port. To put a dissector there, right at the alpha S1 disk level, very much parallel to the disk space. Yeah. So now if you can notice, sir has changed his position on the ports. So now cranially he has RF and caudally he is holding his camera. So this is a very versatile method what sir is using with a 30-degree scope. Yeah. So this is the inferior S1 lamina. Yes. Yes. Spinal catheter junction, what you also got as J line. camera is slightly rotated, if you could appreciate. Yes. At 11 o'clock is S1 again. Crocodile portion or a ligamental flame of cutter. Scissors, scissors.
Right side will be. Right side. Yes.
At 3 o'clock with cranial and 10 o'clock with quarter. And this is 6 o'clock with the penetrate. And this is defecting the lateral attachment of ligament of lemon, which is attached to the margin of SAP, so superior articular process. So that has to be removed. Part of SAP may be removed.
Very important surgical nuance of right-sided pathology being operated from right side is the difficulty is initially when we are working on the lamina. Once the lamina is gone, the right side approach is actually even easier because now your upwards are going in the direction of your nerve. So the only So the only problem is how to remove the lamina, and I think if you can negotiate that part, how Nicholson did it was he used his left hand as working initially, and once he has done the lamina, then he is using the right hand. So that is how he is tackling that problem. The other way of tackling the problem is use a drill.
Sometimes once you go right-sided fusion, it is easier to put stage from right hand or right-sided than on the left side.
Yes. Because the direction of your disc is in the
Working like that. And in lateral view, before operation, you should see that the L5 S1 disc is vertically oriented. It should not go obliquely.
इस साल नहीं आया, मेरे साथ तो आया है।
You can see the people cycling on it. We are trying to indulge this wave of problems lateral attachment to the lamina-facet junction. Because the camera has been, again the position has been changed. Now what you are seeing as on the right side of your screen is the L5 lamina, the under surface of L5 lamina. Yes. Yes, correct. So this 30-degree cameras we used to use in our general surgery training while doing laparoscopic procedures. See the percentage back. Trying to find the fraction. Mind is correctly of my lenses. So that's why we are looking at the superlateral lenses.
साइकिल चलाते हैं अभी सोच रहे हैं
Clearer vision. Also where there is little internal bleeding, they say if you go closer to the bleeding it will stop. And you see now he is very close to the bleeders and your screen is very clean. As you go out, it will become red. cautery setting is ablation on 2 and coagulation on 3. We will use our cautery settings as we go deeper and near the neural structures. Now we are at the shoulder of the right L5. This confirm once again beyond that we are at the we are at the L5 level, the lower end, exactly where the disc is located.
Neeraj or Rohit, you continue your watching and we'll have some lamp lighting also so that we can formally inaugurate the workshop.
Sure, thank you.
I will request Principal Sir, Dr. Prashad and Dr. Avtar Sir, please come. And request Dr. Bansal, please join. Dr. Ashutosh, please come. Dr. Vinod, आइए हमारे गेस्ट को बुला लेते हैं आइए प्लीज डॉक्टर भी आ जाओ जयदीप प्लीज कम
Thank you, Dr. Alvar. All the esteemed guest faculties, operating surgeons, the delegates, in-house faculty and their students. It's a pleasure to watch endoscopic neurosurgery. I have been involved in collaboration with neurosurgeons for more than 25 years, being an ENT surgeon. All the cases of nasal and sinus surgery we operate ourselves, but whenever we venture into anterior skull base, we always had the help of neurosurgeons, and we work collaboration with neurosurgeons, mostly for CSF repairs and for pituitary. It's very good because whatever we learn after either academic workshop or by observing the life surgery that the experts do. That is how the knowledge spreads. I really compliment the Department of Neurosurgery of Heritage Institute of Medical Sciences for organizing such a good live surgical workshop. I thank all the delegates who have come from outside. I thank them from bottom of my heart for being here with us to share and to teach us. On behalf of Heritage Institute of Medical Sciences, I welcome all of you and wish the workshop a great success. Thank you. Thank you.
I'll request everyone to please come to the basement for lunch. As once the OT will start, then you can join. Anil? Hello? क्या बोल रहा हूँ? आओगे क्या लंच करें? अच्छा
आप वापस आओगे ना, मुझे ओटी जाना है, तो मैं क्या करूँ फिर आपके
We are correcting the OT. Maybe you can wait for some time and then we can go for lunch. Lunch is just see. They are saying they are on the desk actually. Neither.
अगर आप जाओ
Please take us to the OT.
केस में वॉश हो जाए
There is a owner of
म्यूट कर लूँगा
You can see how उधर से आएगा। हाँ हाँ अच्छा ठीक है उधर से ले आते हैं ठीक We welcome Dr. Ranvija Dubey from Gorakhpur. He has joined just now. Jaideep is there. Aja. The root fragment of that is coming out. Very big chunk of the bill. I think everyone can appreciate it.
Yes, we can appreciate it. The big chunk coming out.
काम करो चला के कोई देखता
Because the clean, this could have not remove the entire flavor. Only a small bit and
15 लगाया क्या खत्म ये खत्म नहीं चल रहा है ये क्या है 1 लाख रुपये कम हो गया वो वाला चार्ज है लगाना वो वाला चार्ज लगाना जो एक दिए थे आप कौन लगाया है वो लगा लो 56% है ना
तो मैं जुड़ गया हूँ याद
ball probe, get the speed of any adhesions of the this matter, the nucleus, and then you can remove it.
अरे पवन डॉक्टर साहब खाना खा ले निकाल हाँ इसलिए देखिए तो ये उल्टी साइड की डिफरेंट है
कई बार इंफ्लेशन का प्रॉब्लम स्पेशली तो मोटे पेशेंट में तो
लेफ्ट साइड वर्सेस राइट साइड में राइट साइड डिफरेंट हो गई इसका मतलब वो भूख लगा के ऊपर वाला क्या हुआ
just try and see under the single side if any and all kind of display. Using the root, just trying to stop and root fragment.
किसी में आज कट ऑफ प्रोग्राम की स्टूडेंट निकला उसका
The forward slide, so that you can make it and put it down. What might be subvenulous head, that's why you're using the forward is
इसके बाद हाँ बहुत अच्छा डेमोन्स्ट्रेशन
Can take any questions from the audience.
वो एकदम एग्जैक्टली जैसे कि
I showed a nice clean.
वेरी क्लीन और हमारा जो था डिफरेंट केस था मतलब इट इज वेरी लिगामेंटल क्लेवम वाले को निकालना बढ़िया बहुत अच्छा देसी एकदम देसी हाँ हाँ एकदम
वहाँ से निकलने के बाद फिर ये
हाँ बताइए आज नहीं है आज है ना
Beauty of UBE is that you can have absolutely so much range of motion of both of the hands. It is not there when you are working with monofocus.
Rohit, Neeraj, yeah, we have seen the disconnectly nicely. Now people are moving to the lunch. It's okay?
Yes, sir.
We
We
have,
have
yeah,
almost taken out the disclosure. It's
yeah.
okay, sir. We can,
So what we'll have after lunch, we'll have a lecture of Dr. Asutosh, and then you can use the third case, and Gaurav after taking lunch will go there. Okay?
Sure.
Okay, thank you, Dr. Nikunj. Good one, good show. Thank you.
Thank you for the session. Thank you.
चलो भोजन भोजन
उधर ही जा रहे हैं। ठीक है ना, ये कहाँ गया इनका बंदा? हाँ तो कोई दिख ही नहीं रहा है। वही मैं यहीं पे लैपटॉप चले गए। हो गया? हाँ ना है। सेकंड फ्लोर ना। कोई एक फैकल्टी का जो आपने बनाया है इसमें से कोई मिल जाएगी ना, फिर वो रीड नहीं करेंगे, वो एक ही मेल आ गई। मैं अब्दुल बंसल वहाँ करवा देता हूँ।
जाएगा उधर कोई नहीं है इसमें।
लैपटॉप तो लूंगा ना।
हाँ अच्छा अच्छा। कारीगर ने आपको हाँ वही
यूज नहीं हो रहा है क्या उसमें?
हाँ ये काम किया है। सामान एडजस्ट करना
मिल गया होता हमको दे दीजिए मेरा। चल रही है।
हाँ वहाँ तक चल रहा है ना। कितने मिनट लग रहे थे? इधर ही
पूरा कैसे कॉपी कर लो? ये प्राइवेट और जो फोटो प्रोग्राम उसी को कॉपी कर दूंगा।
माफ करें
बैग है पैसे निकाल लें यहीं पे बैठो यहीं अंकित अभी हम फोन करेंगे तुमको तो फोन आना नीचे या इधर ही ऐसा करो इधर आ जाओ ना आईएल हम जहाँ से मिले थे यही पहले हम दो पीस देख के चलिए थोड़ी देर हमको हाँ थोड़ी देर आते हैं आओ इधर आओ पीछे आओ और बताओ और क्या चल रहा है तो फिर बिजी हो गए भाई बिजी तो भाई बिजी तो पहले भी थे बिजी तो पहले भी थे और बिजी हो गए पहले तो इधर उधर कहीं घूम कर लेते थे पहले एक बार तो गाँव वाले कॉन्फ्रेंस में मिले तो तुम बोले बॉस यहाँ पे अगर 2 दिन रुक जाएंगे तो वहाँ पे हालत खराब अब वही है कि 1-1.5 दिन के लिए निकलते बाकी कितने बेड का हॉस्पिटल बन गया 50 बेड मतलब कितनी बार चला जाएगा तो सब ये बढ़िया है वंदे भारत 1.5-2 घंटा धाम वाला आप चलिए ना धाम अयोध्या धाम दिल्ली से बनारस से नहीं बनारस से दिल्ली में बनारस से जो है मेरठ है अच्छा सुबह तो 2 बजे रहते हैं एक 9 बजे 9:10 पे और एक 9:45 मेरठ की वो अयोध्या भाया लखनऊ बरेली मेरठ वो कितनी आने लगती है यहाँ से बस शाम को कल बिफोर ले आई 1.5-2 घंटे में बहुत ज़्यादा चल रहा है तो तुम हीरो सैलरी और तो सुपर अरे बहुत अगर 250 मरीज की होगी उस समय उसकी होगी 6 महीने के अंदर हम कम कर दिए 250 मरीज जो है उस समय देखता है उस समय जोश उस समय अकेले भी थे और बहुत सारी चीजें 25-30 मरीज रहते हैं उनका एग्जाम लेने में हो जाता है 7 महीने हो जाते हैं, उसके बाद सॉफ्टवेयर देख कितना टाइम लगता है, उसके बाद सर्जरी सर्जरी तो जब इतना ऑपरेटिंग छाने रहते हो तो सर्जरी का टाइम मिलता है। जरूरत है क्या इससे बिना आयुष्मान के ना आयुष्मान ले लेना तो मैं फिर नहीं कर पाऊँगा, बिना आयुष्मान कागज कहाँ बनवाया, कागज बहुत सही है, दोनों मिलेगी मैं लोकेशन देखा वो तो भी लड़के का प्लस फ्रीलांसर कागज कौन से हमने 16 में हम ज्वाइन किए थे, फर्स्ट ईयर 18 में एक दिन एक पार्टी में गए थे, 1 महीने पहले एक मुस्लिम महिला पे हम थे, एक लड़का आया उधर से सबको